Good morning. This hearing will come to order. I want to welcome everyone to today's hearing titled Vendors in the OR, VA's Failed Oversight of Surgical Implants. This hearing examines serious problems with the tracking and handling of surgical implants within the VA and follows through on procurement issues revealed in a previous hearing by this subcommittee. According to multiple sources, VA medical centers have allowed surgical implant vendors to participate in hands-on treatment administered to veterans. Based on my staff's initial findings, I asked GAO to investigate these allegations regarding veteran health care and to determine what policies are currently in place. GAO substantiated that several veterans had received skin grafts that had been applied directly by skin graft vendors. GAO found that VHA requires each medical facility to develop its own policy on vendor access, resulting in varying degrees of specificity regarding their participation in patient care. These findings raise serious questions about the extent of vendor involvement in patient care at VA facilities and the lack of clear guidance regarding vendor access. VA's own consent form, as well as industry best practices, state that vendor representatives may be present to provide technical advice but may not physically participate in the procedure. However, GAO's investigation confirms that these policies are being unevenly applied or unenforced. Clearly, national guidance and oversight is necessary to protect veterans who undergo surgical implant procedures. There are also significant problems with how VA handles and tracks surgical implants in veterans. Previous VA OIG audits criticized the VHA for weak internal controls that jeopardize VA's ability to identify and notify patients in the event of FDA product recall. According to GAO's report, released on Monday, these concerns remain and have not been remedied. For some clinical specialties, including gastroenterology, interventional radiology, and pulmonary, identifying information on implants was not tracked in any system. It is troubling to consider that for these specialties, VHA was unable to verify that the items purchased were actually implanted in the patients for whom they were intended. In 2008, VA began developing the Veterans Implant Tracking and Alert System, VISTAS, to track and retrieve identifying information, including the lot and serial number of surgical implants placed in patients VHA-wide. Unfortunately, according to GAO, this system's development was suspended at the end of the fiscal year 2012 due to data reliability challenges, and as of December 2013, development of VISTAS has not resumed, limiting VHA's ability to identify and locate patients who have received implants. Additionally, GAO's report shows that VA has failed to make sufficient progress with prosthetic procurement reform. In a May 30th, 2012 hearing, this subcommittee revealed that VA medical centers and VHA regional network contracting officers misuse waiving authority to spend nearly $3 billion on open market purchases of prosthetics, including surgical implants, rather than procure them through competitive contracts, including those with businesses on the federal supply schedule. As a result of the hearing, VA acknowledged that there are often several options available for implants and that disadvantaged veteran-owned small businesses and others offering these products were being unfairly excluded from consideration. VA indicated that it would implement reforms so that non-competitive and sole source purchases will require justification on a case-by-case basis. GAO's report does contain some good news. VA has made some progress with obtaining national committed use contracts for non-biological implants, such as artificial joints, cardiac pacemakers, heart valves, and coronary stents. Use of these national committed use contracts is the most favored method of procurement for implants under the Federal Acquisition Regulations. However, GAO also reported that no such contracts have been negotiated for biological implants such as skin and bone grafts. Moreover, contrary to a memorandum dated May 23, 2012, from Assistant Deputy Undersecretary Matkovsky, GAO found biological implants were rarely ordered from the Federal Supply Schedule at each VA medical center it visited. According to GAO, overuse of the waiver process continues. They reported that none of the medical centers it visited procured surgical implants in compliance with waiver requirements for open market purchases. Finally, it is most disappointing to note that while VA and VHA now have procurement oversight components, GAO reported that they have failed to impose corrective actions for these deficiencies. In conclusion, VA must continue to implement reforms so that medical centers procure surgical implants that meet patient needs while also ensuring best value. More importantly, VA and VHA must pay much better attention to patient safety concerns regarding surgical implants. It is way past time for VA to develop national policies that set forth the parameters for vendor access to treatment facilities that implement sufficient oversight controls. Additionally, proper tracking of surgical implants is a problem that has been unresolved for far too long, and it must be remedied post-haste. With that, I now recognize Ranking Member Kirkpatrick for her opening statement.
Thank you, Mr. Chairman. I really appreciate having this hearing on the purchase and use of surgical implants. As we know, it's common for the vendors of medical devices to be in the operating room during surgery, but it's very uncommon for them to scrub and to touch a patient. So I'm really interested in the testimony today and whether or not we need to actually beef up our policies on this. On Monday, the Government Accountability Office released a report entitled VA Surgical Implants, Purchase Requirements Were Not Always Followed at Selected Medical Centers and Oversight Needs to Be Improved. So that's what we're concerned about today. The GA looked at 4 VA medical centers and found that these hospitals did not always follow VHA policy regarding documenting open market purchases of surgical implants, including obtaining the necessary waivers to purchase items not covered by a VA negotiated contract. Last year, VA instituted a new policy regarding purchases above the Federal Acquisition Regulations, FAR, micro purchase threshold of $3,000 and below the simplified acquisition threshold of $150,000. Medical facility and regional office officials attributed noncompliance mainly to insufficient VHA guidance and VA staff's inexperience in completing the new requirements. This is a familiar litany to members serving on this subcommittee. It has been noted before that it does not matter how good and thorough the policy and standards are if no one follows them and there are seemingly no consequences for noncompliance. This is what I would like to explore today, in addition to looking at the specific allegations and looking at ways to improve the process. Surgical implants and the larger issue of medical procurement provides us with a classic balancing act of patient and provider choice on one hand and efficiency and savings on the other. These are not, in my view, mutually exclusive concepts, but also they are ultimately very few easy answers. Should there be a greater level of centralization on procurement, or should we provide greater local autonomy while ensuring the policies are followed? Indeed, how do we ensure that VA employees are provided the tools to do their job and help our veterans, but are also held accountable if they do not comply with established policies? On the issue of surgical implants, what policies and structures are in place to ensure that VA staff is kept fully up to date on advances in the field of surgical implants and the availability of different options, while also ensuring that VA's contracting efforts are directed toward items that are clinically advantageous and necessary for patient care? Are decisions regarding which items to include in a VA negotiated committed use contract made from the top down or the bottom up? And more importantly, are these decisions made rigorously and systematically? How effective is the recently instituted program executive office, and does this effort have the staffing level and financial resources to make a difference and improve the process? GAO reported that VHA spent approximately $563 million on surgical implants in fiscal year 2012. That's an increase of 28% over the 2008 levels. I would like to hear from our witnesses today regarding the factors that led to this increase. It is not clear to me whether the increase is primarily due to the practice of open market purchases or to an increase in either the costs of surgical implant or an increase in their use. Patient care and safety is our #1 concern. That is why I'm concerned over allegations that surgical implant vendors' representatives participated in direct patient care. I want to ensure that the VA policies are fully followed in this regard, while also recognizing that at times, vendor representatives can have an important role in providing technical assistance and education to VA care providers. So let us begin the conversation on how best to fix the problems before us today and work to improve the VA healthcare system and the healthcare it provides to our veterans. Spending taxpayer dollars wisely is essential, but providing the healthcare that veterans have earned and deserved is critical. I look forward to hearing from our witnesses today, and I yield back. Thank you, Mr. Chairman.
Thank you, Ranking Member Kirkpatrick. I ask that all members waive their opening remarks as per this committee's custom. With that, I invite the first panel, who are now at the witness table. On this panel, we will hear from Mr. Randall Williamson, Director of the Healthcare Team at the Government Accountability Office. He will be accompanied by Mr. Wayne McElrath, Director of GAO's Forensic Audit and Investigative Services Team. We will also hear from Mr. Roscoe Butler, Assistant Director for Healthcare with the National Veterans Affairs and Rehabilitation Commission at the American Legion. Your complete written statements will be made part of the hearing record. Mr. Williamson, you are now recognized for 5 minutes.
Thank you, and good morning, Mr. Chairman, Ranking Member Kirkpatrick, and members of the subcommittee. I am pleased to be here today to discuss GAO's recent report on VA's purchasing of surgical implants. Surgical implants include biological implants such as skin and bone grafts, and non-biological implants such as cardiac pacemakers and artificial joints. Today I will address 3 areas of our work. First, VA's compliance with federal purchasing requirements and its oversight of surgical implant purchasing. Second, VA's ability to identify veterans who have had surgical implants that are recalled by the manufacturer or the Food and Drug Administration. And third, allegations that surgical implant vendor representatives participated in direct patient care at VAMCs. With me today is Wayne McElrath, who directed our investigative work on vendor participation in surgical procedures at 3 VAMCs. Regarding VA's compliance with purchasing requirements, we found through our work at selected VAMCs that VA surgical implant purchase requirements were not always followed. For example, when surgical implants are purchased on the open market and not through established VA and government-wide negotiated contracts where prices have been specifically established, VAMCs are required to file a waiver justifying why the item is being purchased on the open market. We found that in many cases, such waivers were not being obtained or had incomplete documentation. We also found that in justifying open market purchases of surgical implants over $3,000, VAMCs are not always preparing a written determination that prices are fair and reasonable and or citing an appropriate rationale for sole source award. We found that oversight over surgical implant purchases was not robust and allowed these conditions to persist at VAMCs. Turning now to VA's ability to identify veterans who have received recalled surgical implants, we found that VA is limited in its ability to systematically identify and locate all patients who receive surgical implants, which could be a critical factor if an implant is recalled by the manufacturer or the FDA because of safety concerns. For example, VA, through its own studies, has found instances at numerous VAMCs where data on lot and serial numbers for surgical implants were not entered into VA's computerized system for tracking such purchases. This limits VAMC's ability to match veterans to implants they received. Absent the ability to accurately track implants to veterans receiving them, VA may be putting some veterans at risk in the event that surgical implants are recalled. In 2008, VA began developing a new tracking system to remedy this problem. But VA's efforts to develop such a system are currently stalled due to technical challenges and a lack of funding. Finally, our investigations of allegations received by the subcommittee disclose that in some instances, a vendor representative supplying surgical implants to one of the 3 VAMCs we investigated was participating in direct patient care at that facility. Specifically, at least as recently as August 2013, a vendor was assisting VA clinicians in applying skin grafts or was himself applying skin grafts to several veterans. Without proper precautions, allowing vendor representatives to participate in direct patient care could compromise veteran safety. While VA allows vendors to provide technical assistance and advice during procedures involving surgical implants, national VA policies do not adequately define the degree that vendors are allowed to participate in patient care. Rather, VA relies on VAMCs themselves to develop their own procedures in this regard. Absent definitive national guidelines, VAMCs, acting alone, may develop different and inconsistent guidelines and controls over vendors, which is exactly what we found at the 3 locations we investigated. For example, 2 VAMCs required background screening for vendors accessing the facilities, while the 3rd VAMC did not. Also, at 1 VAMC, written procedures covering vendor access and involvement in clinical procedures expressly prohibits vendors from physically performing any part of a clinical procedure, whereas written procedures for the other 2 hospitals are silent in this regard. Also, we found instances where some VAMCs were not following their own written procedures. While the results of our findings cannot be generalized to VA as a whole, they raise serious questions about the extent that consistent procedures and controls exist with respect to both vendor access to VA facilities and vendor involvement in patient care at facilities nationwide. This concludes my opening remarks.
Thank you, Mr. Williams. Thank you, Mr. Williamson. Mr. Butler, you are now recognized for 5 minutes.
Ranking Member Kilpatrick and members of the committee, on behalf of our National Commander Dan Dellinger and the 2.4 million members of the American Legion, I want to thank you for inviting our organization here today to this hearing to address our concerns with aspects of how VA implements their prosthetic and implant medicine program. As a member of the American Legion System Worth Saving Task Force, I have been privileged to travel to many VA healthcare facilities and see firsthand how programs really work in the field. In both my experience working for VA for many years and in my travel on behalf of the American Legion, I have seen that conditions in the field don't always match what the folks inside the Beltway think they are. There are several problems with VHA policies and implementation of in-plant medicine healthcare. Most of these problems could be fixed with clear written direction from central office and better oversight and consequences to enforce compliance. First, VA still has a problem tracking surgical implants that places veterans at risk. An OIG audit from 2 years ago identified that there are expired surgical devices on VA supply shelves. Further, GAO report and testimony today indicated that VA has an inaccurate tracking capability in recording the serial numbers of the implant surgical devices. The grave concern of the American Legion is that in addition to having expired products on the shelves, veterans potentially could be walking around today with expired surgical implants. The American Legion urges Congress to require VA to implement an automated tracking system that addresses vulnerabilities by, 1, initially recording the serial number of a surgical implant device when procured and placed into VA's inventory, 2, record the expiration date, and 3, that a record tracking flag be put into place to alert VA staff when the product is near its expiration date. As there remain limitations to VA's current supply inventory system and uncertainties surrounding the safety and well-being of veterans currently with implantable devices, the American Legion urges VA to verify that there are no veterans with expired surgical implants and accelerate its timeline to implementing a new prosthetic inventory system that includes these recommendations. Secondly, the American Legion remains concerned that VA does not have an official policy on vendors in operating rooms. While having vendors in the OR to provide technical advice may be medically necessary, it needs to be made crystal clear that veterans have consented and received full disclosure that strictly adheres to a clear, delineated VA policy. VA has admitted that they do not have a specific policy, but indicated the National Center for Ethics in Healthcare noted that the presence of vendors in the operating room is a common practice in U.S. healthcare, and when there are broadly accepted professional ethics standards pertaining to a particular practice, VA does not particularly reiterate those standards in VA policy. Rather, it was buried in VA's consent and regulatory authorities. Third, the American Legion has concern about VA making a regular practice of circumventing the supply schedule. The federal supply schedule exists for a reason, and the vendors on the schedule have been carefully vetted. Many of them are important contracts with veterans and/or small disabled veteran-owned business owners. While the American Legion recognizes and applauds the need to go off schedule in rare circumstances for the medical interests of the patient, it is becoming increasingly disturbing that off-schedule purchases seem to be more the norm than the exception. Let's be clear. The medical health of the veteran is the single most important factor in any decision about health care in the system. System worth-saving visits uncover doctors who choose to go off schedule to order stents for heart surgery because they were uncomfortable with the durability and safety of the stents on the schedule. In that circumstance, you would hope that the doctor err on the side of the patient's safety 100% of the time. That said, if doctors are consistently going off schedule, then either the schedule needs to be reformed or the process reform. No system that is based on circumventing its own process can be considered in anyone's best interest. Again, thank you for the invitation to speak today and keeping a close focus on ensuring veterans get the most out of their healthcare system. We would be happy to answer any questions you might have.
Thank you for your testimony. Mr. McElrath, was GAO able to determine why vendor representatives were allowed to provide potentially inappropriate patient care at the VAMC where the allegations were substantiated?
We weren't able to identify one specific reason, but some of the rationales that were given were a lack of staffing, the difficulty in placing grafts on patients without having some assistance, and also a lack of knowledge relative to the particular VMAC's policies and procedures.
Sure. Mr. Williamson, based on your report, please elaborate on the challenges in trying to identify veterans who may have received a recalled surgical implant.
Currently, VA has a prosthetics purchasing tracking system, or purchasing system, which is used to track surgical implants and match them with veterans as well. That system, VA has done a study of that system and found that lot and serial numbers were oftentimes not entered correctly, or not entered at all, but mostly not correctly, and that really is a detraction in trying to match veterans with implants. Also, VA has clinical services within VA have their own systems. Oftentimes, VAMCs or clinical services themselves will design systems. Their spreadsheets, perhaps, kept on a computer. But the difficulty with those is they're not standardized, and that information is not shared among VAMCs. So you have augmenting systems. VA is developing a new system called the Veteran Implant Tracking and Alert System. It's called VITAS, and that is designed to centralize that. The difficulty is it still relies on input, and the chance of human error is still there. And VITAS will be, have the same kind of difficulty in the sense that it's inputted by people. A way to get around that is to have a barcoding system where you scan the barcode in and it's put in automatically, and that would solve the problem. VITAS is not going that route right now.
Okay.
So those are the challenges.
Thank you. Mr. Butler, did you find that VHA had clear and consistent policy set forth to ensure a proper and ethical procedure when vendors were present during surgery?
We asked VA if they could provide us a copy of their policy, and their response was that they did not have a specific policy. However, the consent was included, the authorization was included in their consent form. So this concerns us that they're using guidance from the National Office of Ethics, but they themselves have not promulgated a standard policy that can be applied consistently across the board throughout VA or VHA.
Thank you. Ranking Member Kirkpatrick.
Thank you, Mr. Chairman. Mr. Williamson, you probably don't know, but the committee knows that I have over 20 years experience in a hospital, and I'm really interested in hearing from our physician members of the committee about this. But it's highly unusual for a rep to scrub in the OR, and in the instances that you mentioned, did the rep scrub?
You want to take that?
Yes. We were talking about instances, or the instances that we identified was the application of biologics or skin grafts. The interviews that we conducted didn't mention the words specifically scrubbing in, but the wound care nurse and the vendor representative actually performed the procedure.
So the nurse actually, the clinician actually performed the procedure, not the rep?
No. From the patient care record, the wound care nurse indicated that the vendor actually applied the skin graft.
Okay, that's very disturbing. Can you tell us what vendor that was?
Out of respect for the investigative process and the fact that we may be making referral to the VA Office of Inspector General for further investigation, we would respectfully request that we provide that information to your committee staff after the hearing.
Thank you. Please do. You know, looking at the overall goal of cost saving and clinician choice, Mr. Williamson, again, I'd like to know how effective is the VHA's program executive office, and do you have ideas for us about how to strengthen and utilize that office?
We didn't look at that specific thing in general, but I think if you want to bring in the idea of I know in the past the subcommittee is very concerned about the use of Section 8123 and whether that's being overused and whatever, and that's certainly something that we looked at in the purchases that we examined during our review. We see that the use of, at least on the surface, the use of 8123 is going down. And used prudently, that is a good avenue for a physician or a clinician to use to provide treatment, the best treatment that he or she sees fit for a veteran. But we noted when we looked at the justifications for sole source procurement that there's much greater use of urgent, compelling, or emergency kind of things. Like it's justified based on urgency, the need for that right away, as opposed to 8123. And so we just see kind of a flop. 8123's that box not being checked anymore, but urgent and compelling need is. So I think that from that standpoint, the efficiency and some of the things that we see there could be improved.
You know, those of us who have experience in healthcare know that the medical device industry changes quickly. There are always new devices coming out. And did you look at the training that the clinicians have in terms of educating them on the best products, the best use? Did you look at all about adequacy of training?
Are you talking about the clinicians or the
clinicians?
Clinicians?
Yes.
We did not. We have in the past done some fairly thorough studies of credentialing and privileging systems that both VA and DoD have. We did not look at that training during this review.
Mr. Butler, did you look at that at all?
We did not.
You did not. Okay. Mr. Chairman, I'm going to yield back. I really want to hear from our physicians on the committee.
Dr. Hulskamp.
Thank you, Mr. Chairman. I am a doctor but not a physician, so there'll be no confusion here. But I do have some questions, particularly of the GAO, and I apologize for my voice this morning. You made some mention to the issue of urgency and perhaps timeliness as far as the purchases on the open market versus those through the VA purchasing requirements. Did you compare cost or quality or any other characteristics? I see you looked at a certain percentage of those. I didn't know if you compared the outcomes and the costs and such.
Could you repeat the last part of the question again?
You mentioned you compared a few purchases, about I believe 6% of a certain subset. Did you look at the cost? Was it more or less expensive? Did you look at the quality? Was there any timeliness as far as comparing those purchases in those two environments?
Yeah, we did not look at whether they got the best price. What we did was rather focus on the documentation and see whether that existed. And in many cases, it did not exist to our satisfaction.
Yeah, and I didn't see that in the report. That's how I wanted to ask. The follow-up question would be, what is the penalty for failing to comply with the VHA purchasing requirements?
Well, they're also governed by the federal acquisition requirements, and you know, I don't know if that's a criminal, possible criminal. I don't think it is, but it's certainly something that can cause a reprimand within the agency.
Any evidence that there was any reprimand or any penalties for?
No, I mean a lot of times when waivers are not obtained, when the reasonableness of the price is not obtained, it was not followed up on, and there was no action plan to correct those kind of weaknesses.
Sure.
No.
Okay. The next question would be, I see your experience of working with the health systems and the Department of Defense as well. Could you give a broad comparison between VA and the DoD? Do they have these similar problems? And are you familiar with that enough to answer?
We haven't looked at similar issues like surgical implants in DoD, if that's what you're talking about. No, we haven't. We did look at how, we did talk to some large healthcare systems like Kaiser on the private sector and try to find out from a standpoint of how they go about putting surgical implants under their contracts, and they're much more aggressive than VA has been in trying to get items under contract.
Mm-hmm. But you didn't look at the cost comparison?
No.
Okay. The last question would be for Mr. Butler, and I'm very concerned about the patient privacy and the instances that were repeated here, and we do not know how often it's occurring, but what are your suggestions? What should be able to be authorized by a patient? If I understood correctly, you believe the language that was used probably authorized the vendor to be in the care situation. Is that your understanding?
No,
What should...
it doesn't authorize, the language in their consent form doesn't authorize the vendor to provide hands-on care. It authorizes the vendor to provide technical advice. But that is a contract between the vendor and the patient. It's not a national policy. So we advocate that the VA establish a national policy that articulates all of the requirements for allowing vendors in the OR, and then use the consent form as the agreement between the vendor and the patient. We believe that if they have a national policy, as I stated, the foundation of VA is predicated upon the statute, the regulations, and the policy that VA adopts. And without a policy, there's no requirements that facilities operate in a consistent manner or fashion.
Well, thank you, Mr. Butler. I agree as well, and I yield back my time, Mr. Chairman.
Dr. Benishek.
Thank you, Mr. Chairman. I'm a general surgeon, and I've been in the operating room lots of times. I've never actually seen a vendor, do a case. So, Mr. Kelrath, was this a couple instances of some vendor putting on a skin graft? Is that what you're saying? Is there any other episodes that you encountered that the vendor was involved with the case, or is it a couple?
We found 2 cases where vendors were actually involved, but there were several instances over a period of time. And speaking to our clinicians that we interviewed during the course of this investigation, we were able to identify those records. If the clinicians had not input that information directly into the patient record, all we would have was witness testimonies. It made it easier for us to corroborate their statements because they actually entered into the patient record who placed the skin graft.
Well, it's frankly shocking to me that this actually happened. I'm a little concerned about, standards that come from Washington to every VA, because all that stuff gets messed. But it seems to me that each hospital should have rules, like the Joint Commission on Hospital Accreditation would not go for this. I mean, this would not fulfill the accreditation needs of any hospital that I know of. And, I think that rules should be developed at the hospital, but they should be, reasonable rules. And I can't believe that, something must have been wrong. I mean, Mr. Williamson, you said that some of the hospitals had no rules about?
The 3 we looked at had written procedures, but those procedures were inconsistent, and they left out some of the things that
Well, in my experience, which is in the private sector mostly, but I've had some experience in the VA system as well. Each hospital is required to have a set of rules and procedures, to be accredited by the Joint Commission.
Right.
Which sets a standard for not only the VA but for private sector hospitals, which I hope that the VA would be in the same boat. And the VA I worked at, were inspected, and this type of stuff I think would fall out of an inspection, immediately if they were aware of it. What can we do? I guess the problem to me is accountability. I mean, nobody at the problem I come up again and again at this committee is that when errors like this are found, nobody seems responsible. There's not one individual that you could point to and say, this was your responsibility and you need to be reprimanded or change your ways, get put in your performance review. Has any of that occurred in any of these circumstances that you know of?
You're talking about the vendor?
Well, no, I'm talking about the hospital people that allow this to happen. I mean, you know, you never get to a person whose responsibility it was, then they get identified. You know, a report is placed in their performance review saying that, you know, they did not comply with the rules of the hospital, and, you know, you may be subject to termination, you may be subject to disciplinary action. The accountability of the administration of the hospital or, you know, the upper echelons is always of importance to me because it seems to never happen where one person gets identified as being a problem, and, you know, a culture of lackadaisical performance seems to be allowed a lot of the time in the VA. So as far as you know, has anybody been disciplined or had a report placed in their...
No.
Well, we'll ask the VA too, but I just was hoping that maybe you guys could... Okay. Let me also ask about this vendor or the purchase of these materials. You know, as a surgeon, I want to work with the materials and the devices that I'm familiar with.
Right.
Okay, so sometimes I would be upset that the VA would, you know, they want to use this thing which I never used, and I'm not comfortable with it. So I want to have the implant or, you know, the device that I'm comfortable with and used to using. And I think that many surgeons have that same, you know, preference.
You're correct.
But there's no reason why when you come to the hospital and set up, you can tell them what you're going to use. And they should be able to set up a plan to purchase that, you know, in a price advantageous. And I think that's a problem. And I think that's a problem related to how this is working here, because the surgeon comes in, the VA won't put it on their formulary for whatever reason, and the guy says, well, I'm not doing the case unless I get the stuff that I'm familiar with. So is there any evidence of that happening?
Well, when we went out to the hospitals, four different hospitals across the country to look at this, we interviewed 28 clinicians. We asked them that very question. Why do you choose surgical implants from the open market in many cases when these are on contract? And it comes down to, number one, the best interest of the patient. In other words, they sometimes have unique needs, and they have implants that best suit the treatment needs of them. The other is, again, like you say, what are you comfortable in using? What have you been trained on in terms of the surgical implant? Also, the literature searches that you might have access to in terms of the effectiveness of these, and the contacts with vendors.
Well, that doesn't preclude the ability of the VA to enter into contracts with people that provide a myriad of different devices. I mean, there's lots of VAs across the country. You know, there may be 10 different devices, and, you know, 100 different surgeons may use each one of those differently.
Right.
So I don't see how that doesn't preclude the ability for the VA to contract with multiple providers for the same type of implant. And that doesn't seem to be happening.
No, the key, you're right, the key is to get more items under contract to get a good price.
Right.
And right now we only have, under national committed use contracts that VA has with vendors, that we only have 9 surgical implants on those national contracts. And one of the things that we recommended was that VA take a more aggressive posture. And
there's only 9?
Only 9, all non-biological implants.
Out of the thousands of implants, different types of implants.
Yeah, they're the highest. I will say that
that's a shocking number.
High volume, high cost.
Because that's a very small number of the different implants that happens. So that's a major deficiency that I think you've identified here at a high level within the VA, because there should be 1,000 different implants on the VA formulary. You know, so
now there are, in addition to the national committed use contracts, there's the federal supply schedule contracts, and there are a number of both biological and non-biological surgical implants on that. So there are their lists to choose from. But the first choice would be the national committed use contracts, because those give you the best prices.
My time has expired. Thank you.
Congressman Walorski.
Thank you, Mr. Chairman. Mr. Williamson, the information is just shocking. And every time we sit in these oversight committee hearings with these reports, which I very much appreciate, it's just shocking, I think, to the American taxpayer and to all of us sitting here who want to provide the absolute finest services to our best and brightest servicemen and women, and to hear these kind of reports. And I guess, one question I have is, it just is shocking to me that there's national medical device tracking efforts already. Would it not behoove the VA to look at something that's already in place if they obviously have not been able to successfully track implants, like the UDI?
I don't think there is any. I don't think that necessarily would provide the information they need on surgical implants. I think that the trouble is there is no centralized system right now. The prosthetics purchasing system has some weaknesses, as I reiterated in my opening remarks. And they're trying to, in addition to that, there are a number of other smaller systems that the clinics, the surgical services are using on their own. So there's two sets of books here.
Is there a barcode system set up in the
No.
VA where those implants are just barcoded?
Not to my knowledge, no. That would take away the human error, and that would probably be the best system. That a system based on something like that would be the best system.
And what about the FDA's UDI system, or what about the American Joint Replacement Registry, AJRR, or something as simple as just having some kind of a standardized policy of a scanner where it's literally just scanned into a system that tracks?
Yeah, I mean that would be something that could be considered. It's a scanning system. It alleviates.
But what happens when we see a recall of some specific device that's been implanted and it's affected X amount of people? How do they know if that's implanted in a veteran?
Well, you've got to rely on your systems that you have already and identify through serial numbers, lot numbers, medical records, other kinds of things.
But when human error puts a wrong code or wrong
well, then I'm not saying it's impossible, because if it was a recall, there are ways to do it. Certainly going through the medical records, but that's a long, laborious project, and it is also subject to human error. Would somebody detect it as they're going through all that?
Thank you, Mr. Chairman. I yield back my time.
Thank you. Dr. Rowe?
Thank you, Chairman, for yielding, and thank you for this testimony. Let me just, having been involved in a lot of devices and having an implantable device in my eye right now, and I actually can read your name, something I couldn't do before my device was implanted. I would like to go about how the procedure, how this actually works in the private sector, and Dr. Benechek alluded to it. Let's say uterine ablation or any other new procedure that comes out. As a surgeon, you have to go and be trained. There are standards in your hospital that require a certain number of hours of training before you can do that. And there may be some technical assistance in the operating room if you're operating a piece of machinery or whatever that you need a vendor there for.
Mm-hmm.
I completely agree that the vendor has no place in actually doing the procedure. You as the surgeon are trained to do that procedure, and the technical advice there are just things that come up that happen during the procedure. So I certainly understand the need, and Ms. Kirkpatrick clearly pointed out, these changes are happening at light speed. Now, I would be very uneasy if I knew that this device in my left eye couldn't be kept up with. We didn't know that there was some reason it couldn't be tracked, because, as you know, and it's mostly in orthopedics, that's where most of the implants are, that sometimes these fail. And if you find a behavior of failure throughout these, you'd like to be able to track down the patients and tell them that, hey, this device has some risk to you or could do this, look out for these symptoms. As a physician, I would want to be able to inform my patients that had happened. So the way it worked in our hospital is when the new procedure came out, you had to have a certain amount of training, be certified in that procedure, and then carry out that procedure a number of times. And then many times I would mentor other people, teach them how to do the procedure. And the old saying in years gone by, see one, do one, teach one, that's sort of gone by the wayside now. you're absolutely right. A system, whether it's barcoding, that's the simplest thing in the world. I mean, Walmart can tell you how many bars of soap went out of Walmart in Tennessee. You ought to be able to keep up with a lens implant or a knee implant and find out who they are. That technology is there. It's not new. So I think those kinds of things are fairly simple. And I don't believe that we have a problem here that can be easily solved with the systems that are in place. And maybe it'll require a new IT. I don't know, Mr. Williamson, whether it will or won't, or whether those current systems are available. But this is not new. I mean, we've been doing this for 25 years, and we're going to continue to do it. And especially as our population ages and more implantable procedures are done. I mean, how many people have you met now that can't go through an airport because they set off the metal detector? They've had so many devices implanted in them. And we have to have a way to track those, because not all of them are perfect. There's no question about it. And the reason it's important to be able to track those is because when you find out what those defects are, it gives the manufacturer and the engineers a chance to improve those and make them better for future patients. So, I mean, I think, Ms. Kirkpatrick, I know your background, and I certainly believe what we've got here is, and I agree with Dr. Benechek, I'm not sure we need a national policy, but each hospital, that's fairly simple stuff. And I will yield to anyone who wants to respond. Mr. Butler, I read your testimony and agree with much of it, but again, this is not reinventing the wheel.
If I may,
yes, sir.
With regard to your comment about the national policy, the local hospitals develop their local policies based upon the national guidance from the central office. So if they don't have national guidance from central office, their local policies may be inconsistent from one facility to the next. So there needs to be consistency across all the VA healthcare system, and that consistency comes from the national guidance provided by the program office out of D.C.
Certainly, I can't argue with that. Some consistency. The other thing I think that we get into as surgeons, and I get this. You know, I like a certain type of suture. Is it Vicryl? Is it chromic? Is it whatever? Do I like staples? Do I like this particular staple? I mean, those things change so fast, and there needs to be some consistency, because error rates go down when you have, there's no question, when you have a policy and a procedure that you go through, just like taking an airplane off. We learned that in our operating room, that the more consistent and you could do it, and the more frequently you did it the same way, the less errors there were. But there ought to be some latitude, because not everybody falls under the bell-shaped curve, as Dr. Benechek clearly pointed out, and what you're familiar and use well and have had good success with. So procuring that, and I understand if you got 10 surgeons, the procurement officer in a VA can't procure 10 different types of suture for that, when it really doesn't make any difference on the long-term outcomes, and the data will prove that. And this should be data-driven and not just cost-driven. And I think, unfortunately, what happens, a lot of times these things are cost-driven and not data-driven. I will yield back my time.
Thank you, Dr. Rowe. Mr. Lamborn from Colorado.
Thank you, Mr. Chairman, and I want to thank you for having this important hearing and for your work on this issue. So I appreciate that. Mr. Williamson, your report noted that the fair and reasonable price determination was not completed for a number of open market purchases that you reviewed and not properly documented in other cases. Does this mean that the VHA was overpaying for surgical implant purchases from the open market?
Not necessarily, but because we didn't look at, again, the cost itself, but we just looked at the documentation that existed to support that. But it does certainly leave, make it more likely the fair and reasonable price wasn't obtained. Even when we examined documentation when there was an explanation, sometimes the explanation wasn't too good. For example, the language might say that it was based on prior prices, and yet the prior prices weren't delineated. So it's just a statement and nothing more. Another case we found, for example, was a case of a bone graft that was supposed to cost $6,000, and the fair and reasonable price determination was based on a price range of other bone grafts that ranged from $3,000 to $20,000. And on the basis of that range, the person determined that the $6,000 bone graft was fair and reasonable. It's probably not the precision that you want in determining that the reasonableness of that $6,000 bone graft. So there, even when the documentation was there, it wasn't very good in many cases.
Okay, thank you. And Mr. Butler, I have a question for you. In your testimony, you indicated that the American Legion is utilizing a system worth saving task force. Can you please elaborate on the task force and what it found regarding implant tracking?
Well, in 2003, our past national commander, Ron Connolly, when he was the commander, he went out and visited over 60 VA healthcare facilities, looking at the quality of care and access within the VA healthcare system. As a result of that, at our national convention, a resolution was adopted that the System Worth Saving Task Force continues those site visits. So every year, the American Legion System Worth Task Force identifies a theme. This year, our theme is a 10-year look back at the VA healthcare, where we're visiting 15 VA healthcare facilities, and we're looking at the access, the quality of care that is provided to American veterans. So with regard to your question about what findings we found as it relates to implants, we haven't really focused. That has not been the focus of our attention, but we're beginning to, since this is a part of the hearing, as we go out on our site visits, we're beginning to ask those questions in terms of procurement and so forth, to see what systems and what concerns veterans have. When we go out to a site visit, we have a town hall meeting with veterans, and we bring those veterans in so that they can tell us what are the concerns and the issues they have. So we're asking veterans what concerns, issues they might have, so that we can, when we meet with the medical centers, we can address those intelligently to find to get their response to those issues. So as we're continuing our site visits, we're beginning to focus on those questions.
Okay, I appreciate your work and the American Legion's work on that. And Mr. Williamson, I have a follow-up question. Does open market, quote unquote, mean the possibility that items are not Trade Agreement Act compliant?
Not necessarily. No, I don't think so on that one. If I understand your question right.
Yeah, what I'm trying to get at is there potential that there are gray market products that the VA is using?
There's always, I guess, a potential, although we did not notice that when we did our work.
Okay, appreciate that, Mr. Chairman. I yield back.
Thank you, Mr. Lamborn. Mr. Williamson, what are the implications of low compliance with waiver requirements for purchasing surgical implants from the open market?
Two things come to mind here. One is an accountability factor. The waiver requirements are there for a reason, to make sure that people go through a thoughtful process, that clinicians go through a thoughtful process when they choose open market items, and that's one factor. The other factor is that the information that VA can glean from waivers has a connection to national contracts, establishing more national contracts. For example, they get information on high volume, high use items that are being, through the waiver process, are being purchased on the open market. What that means then is they can use that to identify items that they should pursue under a national contract. So that's a very important part of having good, solid waiver information.
Okay. And Mr. Williams, your report identified shortcomings in VA and VHA oversight of surgical implant purchasing. How do you think that oversight could be improved?
One of the things that both VA and VHA have done separate studies looking at surgical implant purchasing, and came up with basically a number of the same findings that we did. The difficulty was that when they identified those and talked to VAMCs about them, it was more in an advisory category, disclosure category, as opposed to let's do something about it, let's get it done. And one would expect, and what we expect when we recommend something to somebody, is that they come back with an action plan or something of that nature to make sure it happens. And so that's a large part of what we'd like to see.
Hey, Mr. Williamson, finally, your report discussed low compliance with waiver requirements for purchasing surgical implants from the open market. Why were facilities not fully compliant?
There were a couple reasons. As you know, VA is implementing a new system for surgical implants purchases over $3,000. And it's over the last year or so, it's been a major effort with VAMCs across the country. People that we ask in the VAMCs about why didn't you prepare waivers or why aren't these on file told us that the higher priority was to get this new system in place, and that was one of the reasons. Also, as other members have alluded, physicians who practice in VA facilities often have outside practices. They may be part-time, and so they aren't always familiar with the waiver rules, and that's basically the two reasons that we heard when we asked that question.
Thank you, Mr. Williamson. Ranking Member Kirkpatrick.
Thank you, Mr. Chairman. Dr. Rowe, I agree with you that we should try to solve this problem within the existing policies that we have. However, Mr. Chairman and the committee, if it's the consensus of the committee that we need a new policy, I think we need to be very careful that we protect that local control. Because, doctors, as you stated, and Dr. Benishek as well, we want our physicians to have the tools that they're comfortable with, because ultimately our goal is the best patient care possible for our veterans. So I think we have to be careful and keep that in mind and give our physicians, men and women, the best tools that are available so that they can deliver the best patient care. That said, I'd like the panel's thought about this idea. When a vendor's rep crosses the line and actually touches a patient in the OR, wouldn't it be more effective just to terminate the contract with the vendor? Terminate the contract.
That's certainly a possibility, and again, if you really want to enforce the idea that vendors have no hands-on treatment ability in VA hospital, it's got to be some fairly stringent requirements and penalties. I can probably think of a number of things in terms of proving the whole access process for vendors in VAMC, starting with getting them to sign in at the police office when they arrive. We found, for example, that at one facility we looked at is that the log in the police office for the vendors was supposed to sign in had not been up. The last entry was 2011. So, and we knew that vendors had been in there many times. So there are a number of things in the whole access. It's not just in the operating room or during procedures or whatever. It's the whole access that needs to be changed.
And maybe the procurement process, making sure that those contracts have some clause in there that if a rep actually touches the patient, their contract is terminated. Mr. Butler, do you have any opinion on that?
Well, there may be provisions already in the contract that covers that. They have to look back at the contract and see specific what the contract states. And I would agree that if there aren't any particular provisions that allow that there needs to be something, because that's a violation of what the veteran consented. The veteran, based upon the current consent form, the veteran did not consent for the vendor to participate in the surgery. So clearly, that's a violation of the agreement between the veteran and the clinician.
Right. And my interest is not, again, it's making sure we've got the best patient care possible for our veterans. But let's not make the physician's job more difficult. Let's look at the vendor who actually violated that consent form. Back to the barcode and the tracking. Mr. Williamson, doesn't the VA track medication by barcode already? I mean, isn't there a system?
I believe so, but I'm not sure of that.
Okay. again, I think we should look at what's working in the VA system. I'm pretty sure they track medications. I don't know why they can't track medical devices. Thank you, Mr. Chairman.
Thank you, Ranking Member Kirkpatrick. Dr. Benishek.
Thank you, Mr. Chairman. Oh, I didn't really touch upon the other issue that we're talking about, and that is the tracking. Some of the other members did, but frankly, I just can't believe that doesn't happen either. I mean, like Dr. Rowe mentioned, I mean, it's been going on in the private sector for 25 years, and constantly with every device that I know of comes with a sticker with a barcode on it, and you put it in the chart, and so that it's thoroughly documented, what device is in which patient. And I just can't believe that this goes on. And it brings me back to my same question I had, and that is the accountability of when these errors occur. What can we do better to identify, the people who manage this system and to make them accountable for these errors? Any of you have an idea about that?
Well, keep in mind that people, they're looking at a package and there's numbers all over the package, and there can be a very innocent transposition of numbers. It's not something, it may not be done a lot, but it does happen, and there are enough cases where it leads you to have concern about if a recall exists.
No, I understand that errors can occur, among the OR scrub nurse or the circulating nurse, but that's uncommon. I mean, and I think a procedure like with a sticker where there's not going to be a transposition numbers because only placing the sticker that came with the device in the patient's chart and in some kind of a hospital tracking system and scanned into a computer, that happens all the time. But making sure that system is in place is somebody's job, and that's what concerns me about the VA in general, is that nobody seems to be accountable for things like this when we bring them up in these committees. I mean, we have issues like this that come up within the VA all the time, and we never get down to whose job it was to do that, and are they getting the right oversight?
That's probably a good question. That's probably a good question for VA. I would think that the IT people should be all over that, but again, I think that's a question that you should address to VA.
Well, I'm going to let Dr. Rowe talk as well. Thank you.
Thank you, Dr. Benishek. Ms. Wolarski. Dr. Rowe.
I guess the question that I have now is, we've identified the problems, pretty simple, really. And the question is, what recommendations would you all have? And I agree with Ranking Member Kirkpatrick. You want to make sure that the job I have when I go in the operating room is as easy as possible. I think some of the Dr. Benishek, who's a general surgeon, touchiness about who's accountable is that he knows who's accountable when they put the knife in his hand. It's him. And he didn't have to look any place but the mirror. And with the VA system, we continually try to find out, well, whose job was it that was to prevent this? I think that's a little bit of your frustration, and mine also. But I guess very simply, what recommendations would you all have for us? This is a fairly simple problem to solve, and we do need these folks. And Ms. Kirkpatrick may have hit on something. You can't go back in the OR. That's the death penalty. I mean, for a vendor, that is the death penalty for them. And that company can't do that. And you do need, when you get these new devices, many of them are procedures, are highly technical. And until you have a real sense of familiarity with them, everybody's going to do their first procedure at some point in time, whether it may be some variation of what you've been doing. But when new techniques come out, you go learn those techniques, but somebody's got to be your first one. And, hopefully it goes well, and you need assistance with that. So we don't want to stop that, certainly. But I don't see any reason to ever have a vendor having any hands-on with a patient. I just can't conceive of a situation where you would need to do that. Can you, Dan? I don't either. And so let me yield to you all and give us 2 or 3 things that we need to do, and let's get this done.
Well, with regard to the hands-on treatment of veterans, I think, again, as Mr. Butler said, a national policy or national procedures as a template for the VAMC, so they're not going out doing their own thing, is very important. And so that is, one thing, again, as I said in my opening remarks, we found a variation in inconsistency in that regard. Now, you've heard throughout the question and answers and in my opening remarks the word accountability, and accountability for oversight, accountability for carrying out the waiver and other requirements that go into purchasing. Almost that word goes throughout any of the recommendations we make. You've got to establish accountability and getting people to do what they're supposed to. And it varies as far as who that should be. Sometimes it's the clinicians, sometimes it's the procurement folks. Other cases it's people in Washington, D.C.
So the policies would be a reliable, repeatable tracking system for any implantable device.
Mm-hmm.
Fairly simple technology now should be able to take care of that easily. Number two, there shouldn't be any vendor contact with a direct patient care, I should say, to advise you about how to use a particular piece of technical equipment. That's what they're there for, to turn this device this way. You've seen other surgeons do that. I've certainly used them very successfully in the operating room, but no direct patient contact. And then I think thirdly, the procurement is a little different issue because it does get into, and I do see, like I said, if you've got 10 different surgeons, and we all think we're absolutely right every time, you know that,
right,
and that our way is the best way. So I do understand some standardization, but I think at least those two things we could agree on today and implement those things, and I think would solve most of these problems.
I think that makes sense.
Okay, I yield back.
Thank you, Dr. Rowe. Mr. Lamborn, Colorado.
Thank you. Just a quick comment. I have a plant in my district, and I toured it recently, and they do marvelous work creating these amazing implantable devices, anywhere from little pins and screws to large bone grafts, apparatuses, and things like that. And it's just amazing the amount of work and engineering and experience that goes into one of those. And I just think that they have been a wonderful partner in working with the VA and the medical field at large to improve the lives and the prognosis of patients who have all kinds of, and veterans who have all kinds of medical difficulties. So I just want to make sure that no one ends up blaming them, or in case the VA has procedures that need to be improved. So let's don't lose our focus. I mean, this is the VA that we need to have in front of us, and we're really making sure their procedures are up to speed and that the accountability with the VA is what it should be. So I just wanted to make that clarification. Mr. Chairman, I yield back.
Thank you, Mr. Lamborn. And I want to thank the panel so much for your testimony. And let's see. And you are now excused. I now invite the second panel to the witness table. Our second panel, we will hear from Mr. Philip Matkovsky, Assistant Deputy Undersecretary for Health for Administrative Operations at the Veterans Health Administration. He will be accompanied by Dr. Thomas Lynch, Assistant Deputy Undersecretary for Health Clinical Operations at the Veterans Health Administration. Your complete written testimony will be made part of the hearing record. Mr. Matkovsky, you are now recognized for 5 minutes.
Mr. Chairman, Ranking Member Kirkpatrick, and members of the committee, thank you for the opportunity to appear before you this morning to discuss the Department of Veterans Affairs practices regarding the use, tracking and procurement of surgical implants at VA medical centers. I'm accompanied today by Dr. Thomas.
Make sure that your microphone is on. Could you do that? Is it on?
Perhaps it's not functioning. Can you hear me now?
The light is on, though.
All right. I'm sorry about that. I'm accompanied today by Dr. Thomas Lynch, Assistant Deputy Undersecretary for Health for Clinical Operations. The Veterans Health Administration has made significant changes in the last 3 years to the way we procure surgical implants and prosthetic appliances for veterans. These changes are intended to improve procurement, performance, and accountability while ensuring effective health care delivery for veterans. Beginning in fiscal year 2012 and concluding at the end of fiscal year 2013, we transitioned purchasing of surgical implants and prosthetic appliances valued at greater than $3,000 to warranted contracting officers in our procurement organization. VHA's procurement, VHA's procurement organization hired and provided specialized training to contracting staff to ensure procurements are properly executed, consistent with both clinical requirements and federal and VA policies and regulations. We believe these changes strengthened our procurement performance. Throughout the transition, our main focus was ensuring orders were completed timely and in concert with clinicians' prescriptions. With the transition now complete, we continue to monitor timeliness and accuracy, and we are now auditing procurement quality and increasing our use of negotiated contracts for sourcing implants and prosthetic appliances. As a result of the transition, our acquisitions above micro-purchase limits are now recorded in ECMS, our contract management system, and the Federal Procurement Data System. Our quality audits of these procurements have led to changes in procedures and ordering templates as well. Continuous QA reviews will begin in this fiscal quarter to provide detailed oversight of our ordering process. These reviews will focus on sourcing practices and will be used to improve our utilization of existing national contracts, improve training, and identify further opportunities to place biologics and implants on additional contracts. In FY 2014, we'll evaluate establishment of competed additional national contracts that will be directly informed by our clinical leadership to ensure we're emphasizing clinical quality, patient safety, and value. VHA is currently updating and finalizing our policy for prosthetics procurement. Once promulgated, this new directive will provide comprehensive and clear guidance to VA medical center staff on how to order prosthetics. We are still reviewing the recently released GAO report on surgical implants. Prior to receiving the GAO report, VA had initiated a number of reforms to acquisition. Any further opportunities identified by GAO to enhance our acquisition procedures will be considered in our ongoing process. The presence of vendors in the operating room is a common practice in healthcare settings. There are broadly accepted professional standards pertaining to the presence of vendors in operating rooms from the American College of Surgeons and the American Medical Associations. Physicians use professional judgment to determine when the presence of a vendor in a clinical setting improves the safety and effectiveness of patient care. Currently, VA is working, however, to develop overarching policy regarding the role of vendors. VHA Handbook 1004-01, entitled Informed Consent for Clinical Treatments and Procedures, requires physicians obtain patient signature on a consent form before undertaking specific procedures such as surgery. This policy requires physicians discuss the contents of this form with patients. The form also states that under certain circumstances, the presence of a vendor is important to the success of the procedure. That prior to the procedure, the vendor will sign an agreement to strictly adhere to VA's privacy rules, that the vendor may provide technical advice but will not physically participate in the procedure, and that the vendor will be closely monitored by the VA treatment team. VHA additionally has a comprehensive recall process that is triggered both by our own facilities as well as external notices such as the FDA. This process is overseen by our National Center for Patient Safety, which monitors all recall actions requiring product removal from inventory and coordination with patients. At the facility level, all surgical implants are required to be tracked. Further, for certain implantable devices such as pacemakers, vendors are additionally required to ensure medical device tracking to the patient level so that individuals may be contacted in the event of a recall or problem with the device they received. When a recall is initiated, VHA follows a step-by-step process that begins with removing affected products from our inventory and that further ensures all mandated actions are closed out to 100% complete. This process then moves to identifying patients. notifying patients, monitoring patients, and in certain cases performing clinical follow-up with patients. When recalls do occur, we also work with vendors to ensure all VA patients involved have been identified. Mr. Chairman, we appreciate your support and encouragement in identifying and addressing issues regarding the procurement of surgical implants at VA medical centers. My colleague, Dr. Lynch, and I are prepared to respond to any questions you may have.
Thank you for your testimony. Right. Easy a little bit. All right. Dr. Lynch, was VHA aware of vendor representatives providing direct patient care at VA MCs?
We were not aware until the GAO report was issued.
Okay. Mr. Matkowski, what does VA see as an appropriate role for vendor representatives in the procedure area, be it in the OR, wound care clinic, or any other setting?
We do not see it as providing direct patient treatment. I would indicate that in this one case, after we found out from the GAO report, we did refer this case to our Office of Inspector General ourselves. Consultation support, particular technical advice regarding new technical implants is permissible, but direct patient engagement is not.
Mr. Matkowski, what % of biologic contracts are made on the federal supply schedule and the open market?
We've looked at a couple of these, sir. One of them, looking at the below threshold, so contract actions below $3,000, we have about 70% of those actions are on contracts, so national contracts, regional contracts. In addition, for the biologics, I believe there were about $75 million of acquisitions in fiscal year 13. We have not broken out separately those that were on contract, not on contract, but I believe in the first quarter of FY14, our number is roughly about 40% on national contracts, sir.
Okay. I'd very much like you to provide that breakdown to the committee within 2 weeks. Thank you. Ranking Member Kirkpatrick.
Mr. Matkowski, I appreciate that the VA is working on policies regarding vendors in the OR. I think the concern of this committee is always what's the consequence of violating a policy of the VA. What's your thought about terminating the contract with the vendor whose rep actually touches the patient?
Not to be evasive, Congresswoman, but in this case, we would have to look at it. If they violated the terms of a contract, then an appropriate action would be to terminate their contract with the VA. But at a minimum, they would have performed something in violation of our policy. The difference there would be if it's a quality product, a product that we have on a committed use contract, would we want to terminate the contract nationally for the actions of one vendor? But it's something we would want to monitor very closely.
And I just want to reiterate, the concern of the committee is that a lack of consequences, good policies, but a lack of consequence if the policy is breached. But let me go on to the second point. The GAO report states that the Program Executive Office identifies items
The factor is that the information that VA can glean from
that is the only mechanism for identifying items to be included in these contracts.
Has a connection to national contracts.
That is not the only mechanism, it's one of
more national contracts. For example, they get information on high volume, high use
really took effect in FY13.
Items that are being,
by the end of
through the waiver process, are being purchased on the open market. What that means then is they can use that to identify items that they should pursue under a national contract. So that's a very important part
by the end of the fiscal
having
year,
good,
in fiscal year 13,
solid
there were
waiver
roughly
information.
113
And Mr. Williams,
developed
your report identified shortcomings
life cycle value of
in
those
VA and
contracts is
VHA oversight of surgical implant purchasing.
What they do is
How do
they
you
look
think
at
that
procurement
oversight could
spend
be
in,
improved?
something we call
One of the things that both VA and VHA have done separate studies looking at surgical implant purchasing and came up with basically a number of the same findings that we did. The difficulty was that when they identified those and talked to VAMCs about them, It was more in an advisory category, disclosure category, as opposed to let's do something about it, let's get it done. And one would expect, and what we expect when we recommend something to somebody is that they come back with an action plan or something of that nature to make sure it happens. And so that's a large part of what we would.
So that's a mechanism that allows us to do bottom-up.
And Mr. Williamson, finally, your report discussed low compliance with waiver requirements for purchasing surgical implants from the open market. Why were facilities not fully compliant?
As it moves into contracting, and then contracting.
There are a couple of reasons. As you know, VA is implementing a new system for surgical implants purchases over $3,000. And it's over the last year or so, it's been a major effort with VAMCs across the country.
Could you,
Mr. Mikoski,
people that we ask in the VAMCs about why they
and could you provide the committee with the performance goals and metrics for that?
The higher priority was to get this.
Last question is, you heard Dr. Rose say that the medical devices are changing at light
speed. As other
speed.
members have alluded,
what's your system for testing new devices
in VA facilities
and then
often have
introducing them
outside
to
practices.
the VA system at large?
Maybe part-time, and so they aren't always familiar with the waiver
part of our
rules,
evaluation process that we run with the program executive office, frankly, the OAL National Acquisition Center for a number of years has
Thank you, Mr. Williamson.
Some of this
Ranking Member Kirkpatrick.
Thank you, Mr. Chairman. Dr. Rowe, I agree with you that we should try to solve this problem within the existing policies that we have. However, Mr. Chairman and the committee, if it's the consensus of the committee that we need a new policy, I think we need to be very careful that we protect that local control. Because doctors, as you stated, and Dr. Benishek as well, we want our physicians to have the tools that they're comfortable with, because ultimately our goal is the best patient care possible for our veterans. So I think we have to be careful and keep that in mind and give our physicians, men and women, the best tools that are available so that they can deliver the best patient care. That said, I'd like the panel's thought about this idea. When a vendor's rep crosses the line and actually touches a patient in the OR, wouldn't it be more effective just to terminate the contract with the vendor? Terminate the contract.
Before they are credentialed.
That's certainly a possibility, and again, if you really want to enforce the idea that vendors have no hands-on treatment ability in VA hospitals, there's got to be some fairly stringent requirements and penalties. I can probably think of a number of things in terms of proving the whole access process for vendors in VAMC, starting with getting them to sign in at the police office when they arrive.
Well, that's a great statement
there
that you made, Dr. Lynch, about rigorous
at one facility we looked at,
but something is wrong, right?
The log in the police office, the vendors were supposed to sign in.
Cases. So there's obviously these guys weren't credentialed.
The last entry was 2011.
Be doing cases
and we knew
OR, so that there's a failure there
many
somewhere,
times.
right?
So there are a number.
We would agree that there's been a failure
in the whole access.
Occurred, like,
it's not just in the operating room.
I absolutely agree that a vendor should not be touching a patient. The
and maybe the
GAO
procurement process, making sure that those contracts have some clause in there that if a rep actually touches the patient, their contract is terminated. Mr. Butler, do you have any opinion on that?
It did not happen in the operating room. There may be outside of the already in the contract. It happened during the course of a dressing change. It was not a skin graft. It was a skin substitute, one of the cryopreserved skin covers that are used for wound care. And it did not involve a physician.
Because that's a violation of what the veteran consents.
We have asked our Office of Medical Inspector to go in and evaluate that, regardless of where it occurred, and regardless of the circumstance. Let me be very clear, it should not have occurred.
Clearly,
we do not
that's
believe
a violation of the
in the
agreement
operating
between the veteran and
I see. Okay, well,
the clinician.
I don't have, I'm not.
And my interest is not, again, it's making sure we got the best patient care possible for our veterans. But let's not make the physician's job more difficult.
I just
let's look
to be
at the
very
vendor
clear that
who actually
does not
violated
appear
that
to have been an
consent
event that
form.
occurred in the OR.
Back to the barcode
While
and the tracking.
Mr.
Mr. Williamson, doesn't the VA
All right, well,
track medication
have
by
yet to come
barcode
out.
already? I mean, isn't there a system?
I believe so,
I want
but
to
I'm
touch
not
it again
sure of that.
Okay. Again, I think we should look at what's working in the VA system. I'm pretty sure they track
how many
medications. I don't know why they
people
can't
are
track
in your
medical
department,
devices. Thank you,
Mr.
Mr.
Lynch?
Chairman.
I mean, you're the
Thank you, Ranking
Dr.
Member
Dr. Lynch,
Kirkpatrick.
you're the Assistant Deputy Undersecretary for Health Clinical Operations.
Thank you, Mr. Chairman.
I mean, how many people do you have working for
Well,
you?
I didn't really touch
Directly,
upon the
I have about 15. Indirectly,
the other issue
because
that
of the
we're talking about, and that is
151 care centers
the
that I
tracking some of the
oversee.
other members.
We probably
did, but,
have between 100 to 150,000 people working for us.
Frankly, I just can't believe that doesn't happen either.
You know, that
like Dr.
to me
Lowe
is
mentioned,
I'm
it's been
trying
going
to
on in
get
the
to. I
private
mean, I
sector
think
for
we've
25
identified
years,
the fact
and
that there's
you know,
problems here that shouldn't
constantly
happen.
with every device that I know
issue
of
is that
comes with a sticker with a barcode on it, and you put it in the chart.
The previous testimony, I have
so that's
difficulty with
thoroughly
the
documented.
fact that we never seem to
what
identify
devices in which
a
patient.
person.
And I just can't believe this goes on, and it brings me back to my same
I'm going to tell my
question I had, and that is the accountability of
VA
when
Accountability Act,
errors
which
occur.
Actually make the VA identify
what can we do better to identify
the VA who's responsible for something
the people
that didn't occur,
who manage this system and to make them accountable for these errors?
Okay, so that there's
any of you have an idea about that?
Well, keep in mind that people, they're looking at a package and there's numbers all over the package, and there can be a
write performance
transposition of numbers. It's not something. It may not be done a lot, but it does happen, and there are enough cases where it leads you to
every year that everybody gets a performance review written out.
Exists.
No, I understand that errors can occur, among the OR scrub nurse or not, the circulating nurse.
Yes.
But that's uncommon. I mean, and I think, a procedure like with a sticker where there's not going to be a transposition number, it's going to be placing the sticker that came with the device in the patient's chart and in some kind of a hospital tracking system and scanned in their computer. That happens all the time, but
to get those individuals,
making sure that system is in place,
performance to improve, because
somebody's job,
we ask
and that's what concerns me about the VA in general, is that nobody seems to be accountable
for fixing this. We don't get a name of a person.
Things like this when we bring them up in these committees.
Vague answer. We can never get down to
issues like this that come up
performance
within the VA all the time. We never get down to whose job it was to do that.
I understand your frustration.
Are they?
I think, though, you've practiced medicine as
getting the right oversight.
And I
that's
think
probably a good question. That's probably a good question for VA. I would think that the IT people should be all over that.
That sometimes make it difficult to
separate
accountability from the person and the process.
Well, I'm going to let
and I think that's a challenge we face. We need to identify people who need to have remediation of some form. We also need to be able to identify where our processes and our policies interfere with our people performing the service.
Have you ever written
a
review
question
that
I have now is
we've
identified the problems pretty simple.
And
the question is, what recommendations would you all have? And I agree with Ranking Member Kirkpatrick. You want to make sure that the job I have when I go on operating room is as easy as possible. I think some of the Dr. Benechek, who's a general surgeon, touching this about who's accountable, is that he knows who's accountable when he holds the knife in his hand. It's him. And he doesn't have to look at any place but the mirror. And with the VA system, we continually try to find out, well, whose job was it to prevent this? I think that's a little bit of your frustration, and mine also. But I guess very simply, what recommendation would you all have for us? This is a fairly simple problem to solve, and we do need these folks. And Ms. Kirkpatrick may have hit on something. You can't go back and know, well, that's the death
the accountability.
For a vendor, that is the death penalty for them. And that company can't do that. And you do need, when you get these new devices, many of them are procedures, are highly technical. And until you have a real sense of familiarity with
Thank you, Mr. Chairman. Mr. Mikulski, we've learned in the testimony from the previous panel and then also just here, each VA hospital has its own healthcare industry representative credentialing program. We know that. And requirements often creating discrepancies in both requirements and the enforcement from hospital to hospital.
But there is,
and you may
I don't
allude to this in
see
your
any
opening remarks,
reason
but
to ever have a vendor
Where,
having
could you
any
give us an update
hands-on
on where you
with a
are,
patient.
where the
I
VA
just can't
is in
conceive of a
establishing a
situation where
single
you would need to do that.
standardized
Can you,
credentialing
Dan?
program for use
I don't
across
either.
the
And so
system?
let
And that would
me
direct your
yield to
attention
you
to
all
what's
and
being
give us
considered right
2
now
or 3
in my
things that
state,
we
the
need
state
to
of
do,
Indiana,
and
with the
let's
Indiana
get this
Hospital
done.
Association.
Well, with regard
It
to
has the potential
the
to create more
hands-on
consistent
treatment of
enforcement
veterans, I
compliance.
think, again,
After the
as
GAO
Mr. Butler
report,
said,
could you just give us an update?
a
Where are
national
you
policy or
in coming
national
up with a
procedures as a
centralized
template
program?
for the VAMC, so they're not going out doing their own thing, is very important. And so that is, one thing, again, as I said in my opening remarks, we found a variation in inconsistency in that regard. Now, you've heard throughout the question and answers and in my opening remarks the word accountability. And accountability for oversight, accountability for carrying out the waiver and other requirements.
Okay, and then also, as Mr. Lamborn alluded to, the VA is a very important customer
any of the recommendations we make.
For the medical
You've got
device
to establish
industry.
accountability
Since the implementation of the Medical Device Act a year ago, has the VA seen any negative impact in terms of VA patient access
the
or
clinician, sometimes it's the
access to
procurement
existing
folks.
or any new
Other cases,
technologies,
it's people
and
in
is there a
Washington,
concern
D.C.
going forward about access
So
to
the
new
policies would
technologies
be
as it pertains to the cost of the
a
medical device act?
reliable,
I don't know that I have the
repeatable
specifics on the
tracking
cost factor.
system
Some of the
for any
costs
implantable
will probably
device.
be built into the actual
Fairly simple
provided
technology
price
now
to us,
should be
but
able to
I
take
don't
care of
have
that
those
easily.
details.
Number
I can get
2,
those and come back.
there
We have
shouldn't
not
be
seen
any vendor
negative effect
contact
at this point to
with
access to medical
direct
devices.
patient care, I should say.
Could you provide that to our
advise
to the
you about
committee?
how to use a
Thank you.
particular
Thank you,
piece
Mr.
of
Chairman.
technical equipment. That's what they're there for, to turn this device this way.
Mr.
You've seen
Lamborn,
other surgeons
Colorado.
do that. I've certainly
I
used
think,
them
Mr. Chairman,
very
and this
successfully.
question is for either one of you.
But no direct patient
According
contact.
to the GAO report
And
that
then
we
I
just
think
heard
thirdly,
from, and I
the
quote,
procurement is
a
little
physician who
different
stated that
issue
vendor
because
representatives were present during the application
it does
of
get
skin
into, and I
grafts
do
at
see,
this
if,
VA
like I said, if you've
medical
got
center,
10 different
told us
surgeons,
that
and
he
we
did
all
not
think
know
we're
what the
absolutely
official
right
vendor
every time.
policy
We know
was
that.
at the VA medical
And that
center,
our way is the best
and that
way.
he was unaware
So
that he was
I
not
do
aware
understand
of
some
a VA
standardization,
medical center
but I think
policy
at least
that
those 2
addresses
things
vendor
we
roles.
could agree on today.
It sounds to me
and
like the
implement those
oversight by
things, and I
VA
think
is
would solve most of
lacking
these problems.
when physicians
That
have
makes
not
sense.
been informed
I
and
yield
made
back.
aware of VA policy. What are you doing as an overseer
Thank you, Dr. Rowe.
within
Mr.
the
Lamborn,
VA to
Colorado.
make sure this never happens again?
Thank you. Just a quick comment.
I think we can do this as a two-part.
I have a plant in
first
my
of all, we went back
district,
and
and I
looked at
toured
all
it
of the medical
recently,
centers to verify that we have
and
policies.
they
We
do
have
marvelous
policy
work
across the
creating
board.
these
In this
amazing
instance, this is an individual who, the
implantable
one that we're
devices,
looking at,
anywhere from
there
little
was in
pins
fact
and
a policy,
screws
and it was a violation
to
of
bone,
local policy.
large bone grafts,
I would
apparatuses,
further,
and things
with,
like that, and it's
Congressman
just
Walorski's,
amazing the
comment
amount
on
of work
response,
and
that
engineering
we will be looking
and
at a
experience
national
that goes
policy.
into one of those.
Part of the benefit of a
And
national policy is that
I
it
just
has
think that they
certain
have been
enforcement,
a wonderful
authority that
partner
gets carried
in
with that as
working
well.
with the VA
So
and the
the national
medical
policy will
field
set the frame.
at
Local
large
policies will derive from
to
that.
improve
Training will
the
be
lives
associated
and
with those
the
policies. I
prognosis
agree
of
wholeheartedly with
patients
Mr.
who
Butler,
have all kinds
but
of,
that actually is a
and
sound
veterans who have
practice.
all kinds of medical
That is what we're
difficulties.
doing at this point.
So
Dr.
I just want to
Gibbons,
make sure that
I would reinforce
no
what
one
Mr.
ends up
Matkowski
blaming
said. I would
them
also
or
emphasize that we've asked our Office of
in
Medical
case
Inspector
the
to go
VA
in
has
to help us
procedures that need to
understand
be
why the failure occurred so that we can
improved.
prevent it from
So
happening
let's don't lose our focus.
Thank you.
I
And
mean,
Mr.
this
Chairman,
is the VA that we need to have in
Thank
front
you,
of
Mr.
us.
Lamborn. Dr.
And
Rowe, Tennessee.
We're really
and Dr. Lynch,
making sure their
thank you for your
procedures
35 years of
are
medical
up to
service
speed
our
and
veterans.
that the accountability
I
with the
think
VA
this
is what it should be.
is,
So I
at
just
least
wanted to make that
hope
clarification.
That this situation
Mr.
is
Chairman,
just an
I yield back.
outlier that occurred. And at least
Thank you, Mr.
begin to think
Lamborn.
that it is. I was reading.
I want to thank the panel
it's
so much
very clear in the VA
for
policy where VA
your
hospitals
testimony.
are teaching facilities, which is great.
And
trainees may participate in or observe in
and you are now
treatment /
I now invite the
certain
second panel to the
circumstances
witness
present
table.
a vendor representative, a
Our
company
second
representative.
panel,
It's
we will
important
hear
to the
from
success of the
Mr.
procedure. It's
Philip
true. Prior to the procedure, the
Matkowski,
representative will sign an agreement
Assistant Deputy
strictly adhere to
Undersecretary
VA
for Health
privacy
for
rules. And obviously that
Administrative
policy wasn't
Operations
followed
at
in this
the
circumstance Mr.
Veterans
Lamborn
Health
talked about.
Administration.
The representative may provide
He will be
technical
accompanied
advice,
by
but will
Dr.
not
Thomas
physically
Lynch,
participate in the
Assistant
procedure.
Deputy
That's very clear.
Undersecretary for Health
Representative
Clinical
will be closely monitored
Operations
by
at the
VA
Veterans Health
treatment team.
Administration.
That's pretty clear
Your complete
policy
written
to me.
testimony
That's
will be
not
made
hard to
part of
understand.
the
And VA's
hearing
position
record.
is very clear. I think the AMA and the American College of Surgeons
Mr.
have reinforced that
Matkovsky,
position.
You are now recognized for 5 minutes.
Like Congressman Benishek, I've spent many years in the operating room.
Mr. Chairman, Ranking Member Kirkpatrick, and members of the committee, thank you for the opportunity to appear before you this morning to discuss the Department of Veterans Affairs practices regarding the use, tracking, and procurement of surgical implants at VA medical centers. I'm accompanied today by Dr. Thomas.
Make sure that your
microphone is on.
Perhaps it's not functioning. Can you hear me now?
The light is on. 100% agree with that, and
I'm sorry about
your
that.
evaluation, Dr. Lynch, is correct.
I'm
Secondly,
accompanied today by Dr. Thomas Lynch, Assistant Deputy Undersecretary for Health for Clinical Operations. The Veterans Health Administration has made significant changes in the last 3 years to the way we procure surgical implants and prosthetic appliances.
I can tell you what we're doing is what I
changes are
think are
intended to
several
improve
best
procurement,
practices in VA
performance,
right
and
now.
accountability while ensuring
Any
effective healthcare
implant that
delivery
is
for veterans.
placed in the operating
Beginning in
room
fiscal year
in a VA
2012 and
hospital,
concluding at the end of
not
fiscal
only
year
is there a sticker
2013,
placed in
we
the chart,
transitioned
as
purchasing of
Congressman
surgical
Benishek
implants and
recommended
prosthetic
or
appliances
noted,
valued at greater than
but
$3,000
that information is
to
also
warranted
placed in the
contracting
patient's
officers
electronic
in
medical
our
record
procurement
by the
organization.
circulating nurse at the time
VHA's
of the
procurement
procedure. So there is, in fact, a redundant system. Not only do we have information in the prosthetic system, but we have information in CPRS. If you had a,
Sorry about that again. VHA's procurement organization hired and provided specialized training to contracting staff to ensure procurements are properly executed, consistent with both clinical requirements and federal and VA policies and regulations. We believe these changes strengthened our procurement performance.
Anyway, he did.
Throughout the transition, our main focus was ensuring orders were completed timely and in concert with clinicians' prescriptions.
But anyway,
With the transition now complete, we continue to monitor timeliness and accuracy, and we are now auditing procurement quality and increasing our use of negotiated contracts for sourcing implants
we have a
and prosthetic
process in
appliances.
place that's
As a
run
result of
through
the
our National Center
transition,
for
our
Patient
acquisitions
Safety.
above micro-purchase
Any
limits are now
recalls that are
recorded
issued
in ECMS, our contract management system, and the
processed by the
Federal
National Center for Patient
Procurement
Safety.
Data System.
They have
Our quality
representatives
audits
at
of
the
these
visit and
procurements have led
facility
to
level
changes in
that they
procedures and
contact
ordering
when there is
templates
a
as well.
recall. Two
Continuous
steps
QA
happen
reviews
depending
will begin
upon
in
the nature
this
of the
fiscal
recall.
quarter to
The
provide
material
detailed
is
oversight
removed
of
from
our
the
ordering
shelf,
process.
so it can't be placed.
These reviews will
And
focus
if
on
it's need
sourcing
be, we
practices
identify
and
the
will be used to
patients
improve our
through the
utilization of
prosthetics
existing
package
national
and the
contracts,
operative
improve
record,
training,
and
and
notify the
identify
patients
further
of
opportunities to
the
place
recall
biologics
and
and
what
implants
steps may
on
be
additional
taken
contracts.
to follow them
In
with
FY
that implant.
2014,
In most
we
cases,
will
a
evaluate
hip or a
establishment of
pacemaker is
competed
usually not
additional national
removed, but the
contracts
patients
that will
follow
be
it more
directly
closely.
informed
How long
by
does that take?
clinical leadership to ensure we're emphasizing clinical quality,
I
patient
can't
safety,
tell you because I know the VA dropped the
VHA
ball.
is currently updating and
Big
finalizing
time
our
on
policy for
4 or 5
prosthetic
years, I guess it was
procurement.
almost
Once
5 years ago, we
promulgated, this
talked
new
about the
directive will
colonoscopies
provide
that
comprehensive
identify
and clear guidance
patients
to
and
VA medical
the
center
VA
staff on how
records.
to order prosthetics. We are still reviewing the recently released GAO report on surgical implants.
Are we sure
Prior
you
to
have systems
receiving the
in place
GAO
to be sure
report,
that
VA
my
had
lens
initiated a
implant
number of reforms to
is a
acquisition.
recall that I'm notified?
Any further opportunities
I'm
identified by
comfortable that we
GAO
have
to
good
enhance our
systems,
acquisition
Congressman.
procedures will
I
be
can't
considered
guarantee you
in
that
our
there might
ongoing
not be
process.
exceptions. There are always
The
exceptions in
presence of
healthcare.
vendors in the
But
operating
I'm
room is a
confident
common
that we have
practice in
good
healthcare
systems.
settings.
I also feel
There
that
are
we can
broadly
improve
accepted
those
professional
systems.
standards pertaining
We
to the
can make
presence
them
of
better
vendors in operating rooms
by
from the
using some
American
of the
College of
technology
Surgeons
that we've
and the
developed,
American Medical
as
Association.
the ranking member
Physicians
mentioned, in
use
terms of barcoding
professional
for
judgment to determine
medication.
when the
We
presence of
also
a vendor in a
barcode for
clinical setting
transfusions.
improves the safety and
We need
effectiveness
to look
of
at some of
patient
the
care.
newer technology associated
Currently,
with
VA is
RTLS and
working, however,
barcoding
to
to see if
develop
we can
overarching policy
improve
regarding
the
the role of
efficiency of
vendors.
that system. But I'm
VHA
confident
Handbook
that in the majority of cases we
1004-01,
can
entitled
identify the
Informed Consent for
individual
Clinical
and
Treatments and
assure the
Procedures
provider
requires physicians obtain
and the
patient
patient that
signature
they
on a
have
consent
appropriate
form before
information. There have
undertaking
been some
specific procedures
whopping
such as
failures
surgery.
that
This policy
observed since
requires
I've been here.
physicians discuss the contents of this form with
Indulge me
patients.
just a minute.
The
One
form
final
also
question.
states that under certain circumstances, the presence
procedures
of a
and
vendor is
techniques
important to the success of the procedure.
new
But
devices,
prior to
I
the
should say,
procedure, the
that are
vendor will
tested
sign
by
an
our
agreement
VA
to strictly adhere
physicians.
to VA's
Are
privacy
they
rules.
being added to
That
the
the vendor
federal
may
supply
provide
schedule
technical
or
advice
not?
but will not
Are
physically
they
participate
purchased
in the
on open
procedure.
market
And that the vendor will be closely monitored by the
Two
VA
answers to
treatment team.
that. They would be
VHA
more
additionally
likely
has
to
a
go
comprehensive
into a
recall
national
process that
contract
is
or a
triggered
committee
both
use
by our own
contract right now
facilities
than an FSS.
as well as
The
external
FSS is
notices
somewhat vendor
such
driven.
as the
The vendor will
come and get this process is overseen by our National Center for Patient Safety, which monitors all recall actions requiring product removal from inventory and coordination with patients. At the facility level, all surgical implants are required to be tracked. Further, for certain implantable devices such as pacemakers, vendors are additionally required to ensure medical device tracking to the patient level so that individuals may be contacted in the event of a recall or problem with the device they received. When a recall is initiated, VHA follows a step-by-step process that begins with removing affected products from our inventory, and it further ensures all mandated actions are closed out to 100% complete. This process then moves to identifying patients, notifying patients, monitoring patients, and in certain cases performing clinical follow-up with patients. When recalls do occur, we also work with vendors to ensure all VA patients involved have been identified. Mr. Chairman, we appreciate your support and encouragement in identifying and addressing issues regarding the procurement of surgical implants at VA medical centers. My colleague, Dr. Lynch, and I are prepared to respond to any questions you may have.
Is not only a serious breach of VA protocol, but also violates the veteran's privacy.
Thank you for your testimony.
In accordance with VA's table of penalties, at a minimum, will VA be holding anyone accountable?
Dr. Lynch, was VHA aware of vendor
Chairman, I
representatives
can't comment
providing
on that right
direct
now. It's
patient
under
care
investigation.
and VA
I think
MCs?
we'll have a better idea of the nature of
we were
accountability
not
once we
aware
understand
until
what
the GAO
happened.
report was issued.
But if appropriate, people will be held accountable.
Mr. Matkowski,
Mr.
what does VA see as an appropriate role
you
for
issued a
vendor
memorandum on
representatives
May
in the
23rd,
procedure area?
2012, underscoring
be
VHA
it
policy
in the OR,
on the purchase of
wound care
biologics
clinic, or any
that
other
for the
setting.
past year and a half has been blatantly
We do not see it
disregarded
as
by
providing direct
VHA
patient treatment.
employees.
I would indicate that in
Are
this
you
one case, after
concerned
we found out
that
from
your
the
guidance
GAO
is
report, we
completely
did
ignored without any
refer this
repercussion?
case to our
Or
Office
was
of
the
Inspector
memo just
General
a
of
hollow
Justice.
attempt to say that you did
Consultation,
something to
support,
address this
particular
continued failure
technical advice
to follow
regarding
the law?
new
In
technical
our
implants
hearing in 2012.
is permissible, but direct patient
No, sir, I do
engagement is
not
not.
believe it was a hollow attempt.
Mr.
We had started.
Matkowski, what
At the
percent
same
of
time,
biologic
from
contracts
May
are
23rd,
made
2012
on the federal
to
supply
September 30th,
schedule
2013.
and
we removed
the
all of the
open market?
warrants from our prosthetic staff to be able to purchase
Looked at
above the
a couple of
$3,000
these,
level.
sir. One of
That was
them,
a significant
looking at the
transition
below
for us. Much of
threshold,
our energy
so
went
contract
into making
actions
sure we got
below
that right.
$3,000.
The big concerns we had at the time, and when we
about
testified
70%
at that
of those
hearing, the
actions
hearing before
are
that, and
on
then the subsequent hearing,
contracts, so
my
national
big
contracts,
concern,
regional
frankly, was the
contracts.
timeliness
In addition,
effect
for the
of that
biologics, I
transition.
believe there were
We
about
would be
$75
transitioning the
million
purchasing of a
of
prosthetic appliance
acquisitions
with a vendor
in
waiting
fiscal
on
year
the other
13.
side of the
We have not
transaction.
broken out
So to
separately
complete
those
that,
that were on contract,
most of
not
our
on
energy went
contract.
into that.
But I believe
Now
in
we're
the
looking
first
at
quarter
the
of
procurement
FY14,
compliance.
our number
Our
is
audits are
roughly
looking
about
at the appropriate
40% on national
determination of the
contracts, sir.
justification for other than full and open.
I'd very
If we're
much like
using
you to provide that
8123
breakdown to the
incorrectly,
committee
our
within
audits
2
will pick
weeks.
that up now, and we'll make sure we're compliant. So.
Thank you. Ranking Member Kirkpatrick.
Ranking Member
Mr. Makovsky, I appreciate that the VA is working on policies regarding vendors in the OR.
I appreciate
the
your
concern of
efforts
this
in
committee is
crafting a
always
national
what's
policy.
the consequence
But I just want to remind
of violating
you
a policy of the
my
VA.
district in Arizona
What's your
is a
thought
huge
about
rural
terminating
district.
the contract with
It's
the
bigger
vendor
than the
whose
state
rep
of
actually
Pennsylvania.
touches
It
the
covers over
patient?
half the state. And it's unique in that we do have
Not
a
to be
lot of rural
evasive,
veterans. We also have
Congresswoman, but
25%
in this case, we would have to look at
Native
it.
American.
If they violated the terms of a contract,
I'm always concerned about a
then an appropriate action would
one-size-fits-all
be to terminate their contract with the
policy.
VA.
And I'd just like to
but
know
at a minimum,
how
they
you're
would have
addressing
performed
the
something in
unique
violation of our
challenges and
policy.
needs of
The
rural
difference there would
veterans
be
and
if
our
it's a
Native
quality
American
product, a
veterans.
product that we have on a committed use contract, would we want to terminate the contract nationally for the actions of one vendor?
We're a little bit off
monitor
topic
very
because
closely.
I think once we move into rural
I just want to
areas,
reiterate the concern of the committee is that a lack of consequences, good policies, but a lack of consequence of the policy is agreed. But let me go on to the second point. The GAO report states that the program executive office identifies items that are frequently used and high cost. This implies that is the only mechanism for identifying items to be included in these contracts. Is that in fact
treat and interact
that is not the only
with
mechanism,
patients
it's one of the
remotely
mechanisms.
and
I
provide
have some
rural
numbers
veterans
for our
the same
program
quality
executive
of
office.
service that
It
veterans are
really took
getting in our
effect in
larger
FY13.
It
By the
began
end
in
of
primary
fiscal
care.
year 13, I was directly involved in setting some of the performance goals for that
we have the
organization
ability to use
and
stethoscopes
had tied
and
my
remote monitoring
accountability
equipment,
directly to that
so that I think
success.
we are being
By the end of the
concerned
fiscal
about
year,
the rural
in
veteran.
fiscal year 13,
I
there
came
were roughly
from
110,
Omaha, Nebraska.
113,
Our
I
area
think,
covered about
packages developed by
70 to
that group.
80,000 square miles
Total life
of
cycle
western
value
Iowa
of those
and
packages
Nebraska.
in excess of
We faced
$2.1
some of the
billion
same challenges,
estimated.
and we
What
found
they
the use
do
of
is they
telehealth
look at
very
our
effective
procurement
in delivering
spend
that
in
care.
something
VA
called
is actually
MedPDB,
now
the
looking
medical
at newer
product
models
database
which
that we
will
share with
deliver care
DoD. We look
directly
at the
into
things we
patient's
buy,
homes by
and where we
connecting
don't have
physician
items on
and
national
patient across the
contract,
internet
we
so that they
identify
can
them as
interface directly
opportunities.
in the home.
That is one
So I
mechanism.
think
It's
we
not the
are
only
concerned
mechanism.
about
Another
the rural
mechanism we
veteran.
use
We are
as
concerned
we
about the
transitioned
veteran that
away,
can't make
I
our
just want to
facilities.
emphasize,
And I think we
in a
do
period
have
of
some
about
tools
18
to
months, we
provide that
removed
care.
1,100 contracting officer warrants from prosthetic staff and
in my district.
transition
You know, one of my
procurement
concerns
staff.
is, though,
We now have
communication
about
between the VA
378
hospitals and those
prosthetics
rural veterans
contracts
and
at a
Native American
regional and
veterans,
local level that we
especially if
didn't
you've
have
got a
before.
device recall.
Those total
So just
in a
hope that
value
you'll keep that in
annual
the
of
forefront of your minds as you go through the development
So
of the
that's a
policy.
mechanism that allows us
My
to
other
do
question is
bottom-up.
really,
I believe you
excuse
had
me,
made the
process.
comment about top-down
The
versus
GAO
bottom-up.
report
The
indicated that in
clinician preference is
2011,
indicated, and
the
we can find it in
VHA
buying
established a
patterns.
program
We had
management
hoped that this
office for
transition would allow us
prosthetics
to identify
to
those spend
identify
patterns
additional surgical implants
as
that
it
could be
moves
made
into
available
contracting, and then contracting would
excuse me,
establish
through
local
national
and regional
committed use
contracts,
contracts.
and then subsequently
However, an
we would
official told
establish
the
national
GAO that the
contracts.
office was
We are
unable
evaluating
to focus on
biologics
developing
contract.
national
It's going to be
committed
a
use
complex
contracts
contract, but that
because
would be
of
a national
staffing
committed use
constraints.
contract like we
So
have
would you
with
explain to the committee
Could you,
how the office
Mr.
is
Mikulski,
supposed
can
to
you please
function?
speak a little closer to the
Where
microphone?
is,
Thank you.
where in the organization
and can you
structure of
provide
VA
the
is it
committee with the
located,
performance
VHA?
goals and metrics
Does it
for
have the
that
necessary staffing
system?
and financial resources? To
Last
make
question
a
is,
difference and improve
you
the
heard Dr.
process,
Rose say
and
that
do
the
you
medical
believe this office
devices
is
are
capable of
changing at
performing
light
the duties
speed. And
you have assigned
what's your system
that
for
office is
testing new
located in,
devices
VHA's
and then
corporate office
introducing
in
them
what we call
to the
patient
VA
care
system at
services.
large?
The national program director is on board.
I'm going to defer to Dr.
Lynch for some of this, but part of our evaluation process that we run with the program executive office, frankly, the OAL National Acquisition Center for a number of years had helped the VHA in some of this work. We get product samples from the vendor community, so clinicians who are a member of our selection team are literally evaluating products as part of that process. That's different than the federal supply schedule mechanism, which is a much more top-down approach. Not negating the value of either, but it would be direct testing of the product offering on the part of clinicians. And then I'll defer to Dr. Lynch for the research and evaluation of new technologies.
Let me just try and comment a little bit about the introduction of new technology and the process. I think Congressman Rowe and Congressman Benishek discussed that earlier. The VA does, in fact, have a very rigid process of credentialing and introducing new products into the VA. So physicians are expected to undergo specific training. This is actually specified in our credentialing process. When they actually begin to do the process, if appropriate, they will do it under supervision for a period of time before they are credentialed to perform it widely without supervision. So I think we have a process that's very similar to that discussed by Congressman Rowe. In terms of introducing new procedures and assuring that there's competence on the part of the physician to perform that procedure.
Thank you. I yield back, Mr. Chairman.
Process of development. I mean,
thank you,
Can you elaborate on what that was and what
Dr.
is the
Benishek?
are we not using that, or what is the mechanism that you're using that?
Well, that's a great statement there you made, Dr. Lynch, about rigorous
how does that work?
Rules for
First of all,
credentialing, but
VITUS
something
was
is
an
wrong,
attempt
right?
to
Because I mean,
integrate the
some
systems
vendors
we have that
were
track
doing
implants.
cases. So there's obviously these guys weren't
Was
credentialed
conceived and
be doing cases
during initial
in the OR,
implementation,
so that there's a failure there
evaluation
somewhere, right?
was not
But
found
let
to
me
be
would agree that
functioning
there's been a failure
So
if this
at
actually
the
occurred
moment
like
we have
been
pulled
described.
back.
I absolutely
We're
agree that a
relying
vendor
on
should
the
not
National Center
be
for Patient
touching a
Safety,
patient.
who tracks
The
recalls.
GAO did
We're
not
relying
share the
on their
specifics of this
interface
case
with our
with
networks and
us.
facilities.
We have done
We
some
have,
background.
patient safety
We think we
managers at each of
understand
our
what
facilities
happened
who work
and
with the
where it
National Center for
happened.
Patient
It
Safety,
did not happen in the
to
operating
receive the
room. It
recall,
happened outside
assure
of the
that any
operating
shelf
room.
product is
It happened during the
immediately
course of a
and then
dressing
work with the
change.
facility and its
It was
databases
not
to
a skin
identify any
graft, it
patients
was
who may
a
have had
skin
a particular
substitute, one of the
implant placed,
cryopreserved
so
skin
that we can
covers that are
inform the
used for
patient and
wound
the
care.
provider
And it did
ensure
not involve a
appropriate action is
physician.
being taken.
We believe it
Has this
involved
actually
a
occurred
mid-level
under your
provider.
tenure there? Have you seen
We
anything
have
that
asked our
happened that you're
Office of
aware of?
Medical Inspector to go
It
in
has
and
occurred
evaluate
seamlessly.
that.
There have been,
Regardless
I
of
think,
where it occurred and
about
regardless of the
46
circumstances,
recalls
let me
over
be
the
very
past year
clear,
that have been
it should not have
mediated by
occurred.
the National
But
Center
we
for
do
Patient
not
Safety.
believe that it occurred
I
in the
can't
operating room
itemize
at
those
this time.
for you.
I see. Okay, well,
13 of those
I don't have,
involved
I'm not privy to the
biologics.
details
They were all
either.
biologics
So,
that were placed
I mean,
in the
obviously we need to get
so we should have record of the implantation.
So then that
but I just wanted to be very clear that this does not appear to have been an event that occurred in the OR. while a patient was asleep,
figure out if
while a
they've
patient
done
was
any of
under
those
anesthesia.
implants.
They would
All right,
just
well,
go back and
I guess
review
those
the
facts
appropriate
have yet to
records
come out.
see if
It's
any
just
of those
that,
are implanted in a patient, and
I want to
link
touch
that
again on
implant to a patient. Yes.
The accountability part.
You know how,
I mean,
does that take a long time then? Or
how many
is it done
people
by,
are
on
in your
computers?
department, Mr. Lynch? I mean, you're
the search is done by computers, yes.
Dr. Lynch, you're the Assistant
And it's
Deputy
also tracked
Undersecretary
on a
for
website,
Health
so, you know, an
Clinical
internal,
Operations. So are there,
National Center for
I mean,
Patient Safety will issue
how many
an
people
alert,
do you
goes
have
to a
working
patient
for
safety
you?
officer at the visit,
Directly,
oversees
I
the
have
patient
about
safety
15.
officer at the
Indirectly, because
And,
of the
depending upon the
151 care
criticality of the
centers
alert
that
notice,
I
there's a
oversee,
requirement to have
we
100%
probably have
compliance by a
between
given
100 to
date.
150,000
And that date is
people
set by
working
the
for us. Sir.
criticality of the alert.
You know, that
there's a
to me is
requirement that
I'm trying to get to. I mean, I think we've identified the
communicate
fact
with
that
the National Center for
there's
Patient
problems
Safety
here that
to
shouldn't
indicate
have
that the
happened.
appropriate action has been taken.
My issue is that, and you've heard me say it if you listen to the previous testimony, I have difficulty
I
with
just got this answer
the fact
here.
that we never seem to identify a
response
person
to your answer,
who's responsible for the follow-up. And I'm going to tout my legislation. You know, I've got this patient
saying that the
this
National
VA Accountability
Center for
Act,
Patient Safety
which
does not track
would
biologics.
actually make the VA identify
The National Center
somebody
for Patient Safety
within the
does
VA
not
who's responsible for
specifically
something
track
that
the
didn't
product.
occur,
The facility
for
does.
example, to an
The National
Inspector
Center
General
for Patient
report.
Safety, however, does,
Okay, so that there's
does track
actual,
the recall notices for biologics and does pass them
accountability by
through
a
to the
manager
network and the
if we
facility
didn't
when
comply with
appropriate.
an IG report.
All right,
So,
well,
do you ever write
In
performance
fact, there were
reviews
13
on any of these
recalls
people that
within, I
work for
believe,
you?
the past year that did relate to
I write the
biologics
performance reviews
that were
for the people
managed
who
by the
report to
National
me
Center for
directly.
Patient
Yes, sir.
Safety.
So
all right, well, that's
every year then everybody gets a performance review written out?
At a previous date, apparently.
My
So
direct
The,
reports, not
the
for
distinction is
everybody
that,
across
at
VHA.
the
But
National
but I
Center
mean
for
those
Patient
15
Safety,
people
they're
that you
not
talked about.
keeping
Yes.
the list of
And
the
those
individual
15
patient
people,
and
each
the
have
implant
15
of that
people until you get to
patient.
the
That is not
115,000.
NCPS's charge.
Correct.
It's their
Talking about.
charge to link
Correct.
to the FDA, find an incident report
From
the
my
medical
position
center,
here,
and
it's
trigger the
tough to
recall
get
action, set
the
goals,
bureaucracy, the
measure
size that
compliance.
you're talking
The
about,
tracking is done
150,000
both in
people
CPRS
somewhere below you
and
in
the
the chain of
prosthetics
command,
buoy that will track
to
that
get
group.
those
So there are
individuals
policies that require us to record the serial number and
performance to
associate that
improve,
with the
because
individual
whenever we ask
Right,
for
and I think, just
the name of the person who
interject for a
is
second, what we've got is
responsible for
testimony,
fixing this,
and,
we don't get a name of a
certainly
person.
evidence in
We
the
get
DO analysis
a
is
vague
that you
answer.
are
We
not
can never get
effectively
down
tracking
to improving
this
people's
information, and that is a
performance
problem for patient safety.
within the bureaucracy.
Check
Do you understand what I'm kind of getting to?
I understand your frustration.
Actually,
I think, though, you've practiced medicine as I have. And I think you also appreciate the complexity of medicine and the interaction between individuals,
Thank you, Mr. Chairman.
processes,
Mr.
and
Rakovsky, I
policies.
just wanted to ask a
But
follow-up on
sometimes
the
make
issue
it
of medical
difficult
device
to
tax.
separate
The reason I'm asking that
accountability
question, the reason I'm
from the
concerned about it,
person
and I've
and the
repeatedly asked the
process.
question of the
And
VA,
I think that's a challenge we
because
face.
we've had
We
complaints
need
in
to
my district,
identify
which is in
people
northern
who
Indiana,
need to
of
have
long waits
remediation of
for
some form.
medical
We also
devices,
need to be able
hips,
to identify
knees.
where our processes and our
Veterans have been
policies
asking
interfere
if
with
they
our people
can,
performing
why
good
the VA
service.
can't
Have you ever
refer
written
them
a
to
review
private
that
hospitals, refer them to somebody else,
recommended
get them the
remediation
treatment
or
because of enduring pain.
performance
And
improvement?
I posed the question to the VA.
I have put
way back
several
in April of
individuals
last
on a
year,
performance
of saying,
improvement
what
plan.
is
Yes,
this
sir.
impact going to be? Is
So
there going to be an access
nobody ever
issue?
lost their job
Which
or
I've
been
never received
transferred.
an answer on, but from what I'm hearing in my district, in that district, there is
circumstance,
potentially an
there were
access
15
issue.
I have
And the other
not
question I
fired
have was on this
anybody
issue
or
of
transferred
funding.
anybody, no, sir.
And I
And how
re-asked
long
the
have you
question
been
to the
in the
VA
position?
back in November.
I've been in this position for about
on
a
the
year.
committee, and
I've
somebody was
worked
here
in the
representing
VA
the
for
VA,
about
and they said they'd
35
get back
years,
to us, and they never did. I've never had an answer in 60 days.
You know, I
And the
admire
reason
your
I'm
service to
reposing
our
the
veterans.
question is to you
I
today,
really have a problem
especially
with this,
because
and
you're
I
here
hope that
testifying on this
the remainder
specific
of
issue that we're talking
the
about.
staff.
When
we got
can you
this
give me,
Patient
even if the
Accountability Act
VA's
through the
answer
committee, but I was
is
hoping
that the
that
dollar
you
value
all
is
will
minimal,
tell our
all I want
Florida
is the
to the
dollar
village
figure
for
the
this,
VA assigns to
patient
the medical
accountability act, so we
device
can
impact.
improve the
When can I
accountability
get that dollar
of people
figure
in the
that
VA.
you guys are
I find it very
assessing to
frustrating.
the medical device impact?
Dr.
Can you
Lynch,
tell, because
about, you know, how
my
the
fear is if I walk out of here
performance is.
today
With my
and I don't
time,
have
sorry.
some kind of an agreement with the VA today,
Wolarski,
I waited
Indiana.
60 days.
Thank you, Mr. Chairman. Mr. Makovsky, we've
When
learned
can
in
you
the
provide
testimony
me the
from
answer?
the previous panel and then also just here, each VA hospital has its own healthcare industry representative credentialing program. We know that. And requirements, often creating discrepancies in both the requirements and the enforcement from hospital to hospital. And you may have alluded to this in your opening remarks, but I couldn't hear you real well. could you give us an update on where
So I guess my response
where
to
the
that is
VA
that given
is
the
in
VA 60
establishing a
days
single
and no
standardized
response, both
credentialing
verbally
program
and
for
in
use
writing,
across the
can you
system?
provide me with that
And I would
information
direct your attention
by
to
the end of
what's
the week,
being
by
considered
tomorrow,
right now
5
in
o'clock?
my state and the state of Indiana with the Indiana Hospital Association.
I want to do a good job
It has
and make sure we get
the
it done
potential to
right.
create more consistent
But my
enforcement
concern is
compliance.
nobody's answered the
After that
question.
GAO report,
We've done
can you just
everything
give
here,
us an
and the
update? Where
complaints that
are
I
you
am
in
receiving
coming
from
up with
veterans
a
who are
centralized
waiting
program?
for these products has to lead me to
I would
believe that there
separate
is
the
an
credentialing
access
and
problem in my district.
privileging
Is
question
there
with the
also
vendor
a
policy.
dollar
And
value problem
quite frankly,
with funds available
we
to
agree
VA,
with
and
Mr.
is there
Williamson
an
and Mr.
economic
Butler
impact? So my
that
concern
a national
is
policy
because
would
of the
help
fact
there,
that veterans are
and that
complaining
policy
and
sets
the
the
pain that they
guideline,
are
and
in
then
the
from that, the
meantime,
local
and
policies
the
would be
issue of
derived.
asking to even
We've
go
just
to private
begun,
hospitals
so
to go elsewhere.
I
Well,
can't give
asking
you a
if the VA
specific
would reassign
timeline,
them.
but at the direction of the Undersecretary, he wants us to look at this and establish some form of national guidance.
Okay, and then also, as Mr. Lamborn alluded to, the VA is a very important customer partner for the medical device industry. Since the implementation of the medical device tax a year ago, has the VA seen any negative impact in terms of VA patient access?
Today we have had a
the
chance
access
to
to
hear
existing
about
or any
many
new technologies, and is there a concern going forward about access or new technologies as it pertains to the cost of the medical device tax?
I'm not convinced that VA has taken
I don't know that I
the
have the specifics on the cost factor. Some of the cost would probably be built into the actual provided price to us, but I don't have those details. I can get those and come back. We have not seen any negative effect at this point to access to medical devices.
Could you provide that to the committee?
We will.
Thank you. Thank you, Mr. Chairman.
Number one, to discover the extent
Mr. Lamborn,
of
Colorado.
VA inappropriately
Thank you,
allowing
Mr. Chairman.
members to participate
And this
in
question is for either
hands-on
one of
surgical
you.
procedures.
According to the
Two,
GAO
to
report
address
that we
the
just heard
absence
from,
of an
and I quote,
operational tracking system
a physician
that
who
would
stated that
allow
vendor
VA to
representatives
determine
were
what
present
implants
during the
were administered to
application of
veterans
skin
in
grafts
case of an
at this
emergency.
VA medical center,
Three, to identify
told us
the
that he did not
reasoning
know
and
what the
effect
official vendor
of
policy
VA's
was
failure
at
to
the
procure
VA medical
biological
center,
implants on the federal
and that he
supply
was
schedule,
unaware
as
that he was
well
not
as
aware
its
of a
rampant
VA
and
medical
incorrect
center
use of
policy that
waivers.
addresses
Four, to
vendor
require
roles.
VA officials to
It
explain
sounds to
their
me like
inadequate
the
response
oversight
to
by
these serious
VA is
problems and
lacking
determine what
when
steps,
physicians
if
have not
any,
been
are
informed and
being
made
taken to
aware
correct them.
of
I ask
VA
unanimous
policy.
consent that all
What are you
members have
doing
5
as an
legislative
overseer
days to revise and
within
extend
the VA
their
to make
remarks
sure
and
this never
include,
happens again?
extraneous material.
I think we can do this as a two-part.
Without objection,
First of all,
I
we
would
went
like
back and
to
looked at all of the
thank
medical
all
centers to
witnesses,
verify that we have policy.
audience
We do have
members,
policy
for joining
across
in
the
today's,
board.
conversation.
In this instance,
With
this
that,
is an
this hearing
individual
is
who,
adjourned.
the one that we were looking at, there was in fact a policy, and it was a violation of local policy. I would further, with Congresswoman Walorski's comment in my response there, that we will be looking at a national policy. Part of the benefit of a national policy is that it has certain enforcement authority that gets carried with that as well. So the national policy will set the frame, local policies will derive from that, training will be associated with those policies. I agree wholeheartedly with Mr. Butler that that actually is a sound practice. That is what we're doing at this point.
And Doctor, do you have anything to add to that?
I would reinforce what Mr. Matkovsky said. I would also emphasize that we've asked our Office of Medical Inspector to go in to help us understand why the failure occurred so that we can prevent it from happening again.
Thank you. And Mr. Chairman, I yield back.
Thank you, Mr. Lamborn. Dr. Rowe, Tennessee.
And Dr. Lynch, and thank you for your 35 years of medical service to our veterans. I think this is, at least I hope that this situation is just an outlier that occurred. And at least I'm beginning to think that it is. I was reading, it's very clear in the VA policy where VA hospitals are teaching facilities, which is great, and trainees may participate in or observe in this treatment/procedure. In certain circumstances, the presence of a vendor representative, a company representative, is important in the success of the procedure. That's true. Prior to the procedure, the representative will sign an agreement to strictly adhere to VA privacy rules. And obviously that policy wasn't followed in this circumstance that Mr. Lamborn talked about. The representative may provide technical advice but will not physically participate in the procedure. That's very clear. The representative will be closely monitored by the VA treatment team. I mean, that's pretty clear policy to me. That's not hard to understand.
I think VA's position is very clear. I think the AMA and the American College of Surgeons have reinforced that position. And like Congressman Benishek, I've spent many years in the operating room. I have never seen a vendor representative scrub on a case. I have seen them there for technical information. I have seen them there for calibration of equipment that is placed. I have never witnessed a vendor representative scrub. I think this was an outlier, but I think it emphasizes the importance of understanding why it occurred so we can assure it doesn't happen again.
I 100% agree with that, and I think your evaluation, Dr. Lynch, is correct. Secondly, the tracking system, I think, is something that is not a major obstacle with today's technology. It should be fairly simple. Could you elaborate on that? Or would you?
I can tell you what we're doing in what I think are several best practices in VA right now. Any implant that is placed in the operating room in a VA hospital, not only is there a sticker placed in the chart, as Congressman Benishek recommended or noted, but that information is also placed in the patient's electronic medical record by the circulating nurse at the time of the procedure. So there is, in fact, a redundant system. Not only do we have information in the prosthetic system, but we have information in CPRS, the patient information.
If you had as you know, a number of years ago, there was a new ceramic hip that fractured. One of my he didn't think it was so funny. Neither did his mother. He put in his own mother. I would have never done that. I wouldn't touch my mother with a 10-foot pole. But anyway, he did, and well, she yes.
Would she be too demanding for you, Congressman?
But anyway, it fractured, and he had a way, because of the tracking system, to be able to get this out and replace it.
We actually,
the system, do you have that available now? Is that up and running and we just don't know about it?
We have a process in place that's run through our National Center for Patient Safety. Any recalls that are issued are processed by the National Center for Patient Safety. They have representatives at the visit and facility level that they contact when there is a recall. 2 steps happen depending upon the nature of the recall. The material is removed from the shelf, so it can't be placed. And if it's need be, we identify the patients through the prosthetics package and the operative record and notify the patients of the recall and what steps may be taken to follow them with that implant. In most cases, a hip or a pacemaker, it's usually not removed, but the patient's followed more closely.
How long does that take?
I can't tell you.
Because I know the VA dropped the ball big time on 4 or 5 years. I guess it was almost 5 years ago. We talked about the colonoscopies and identifying patients, and the VA records. There was a huge drop ball there. Are we sure? Do you have systems in place to be sure that if my lens implant doesn't, there's a recall, that I'm notified?
I'm comfortable that we have good systems, Congressman. I can't guarantee you that there might not be exceptions. There are always exceptions in healthcare, but I'm confident that we have good systems. I also feel that we can improve those systems. We can make them better by using some of the technology that we've developed, as the ranking member mentioned, in terms of barcoding for medication. We also barcode for transfusions. We need to look at some of the newer technology associated with RTLS and barcoding to see if we can improve the efficiency of that system. But I'm confident that in the majority of cases we can identify the individual and assure the provider and the patient that they have appropriate information regarding.
There have been some whopping failures that I've observed since I've been here. One, if you'll indulge me just a minute, one final question. The procedures and techniques are new devices, I should say, that are tested by our VA physicians. Are they being added to the federal supply schedule or not? I mean, are they purchased on open market purchases?
2 answers to that. They would be more likely to go into a national contract or a committed use contract right now than an FSS. The FSS is somewhat vendor driven, so the vendor will come and get itself on the schedule listing for the most part. But we have a team. I had mentioned it before. It's broken into a number of different domains: a prosthetics domain, a surgery domain, nursing, you name it, and looks at our spend pattern and then moves things into committed use contracts through that process.
Okay, I thank you. I yield back. I thank you for indulging me.
Thank you, Dr. Rowe. Mr. Matkovsky, recently VA unilaterally deleted Biologic from VA's federal supply schedule contracts, then did an immediate about-face by putting them back on schedule. Was this related to the lawsuit filed against VA on this issue?
Mr. Chairman, I do not have information on that, if I can take that one for the record.
Very well. Dr. Lynch, vendors performing operations on veterans is not only a serious breach of VA protocol, but also violates the veterans' privacy and thereby HIPAA. In accordance with VA's table of penalties, at a minimum, will VA be holding anyone accountable for these failures?
Mr. Chairman, I can't comment on that right now. It's under investigation. I think we'll have a better idea of the nature of accountability once we understand what happened. But if appropriate, people will be held accountable.
Mr. Matkovsky, you issued a memorandum on May 23rd, 2012, underscoring VHA policy on the purchase of biologics that for the past year and a half has been blatantly disregarded by VHA employees. Are you concerned that your guidance is completely ignored without any repercussions, or was the memo just a hollow attempt to say that you did something to address this continued failure to follow the law from our hearing in 2012?
No, sir. I do not believe it was a hollow attempt. I thought we had started. At the same time, from May 23rd, 2012 to September 30th, 2013, we removed all of the warrants from our prosthetic staff to be able to purchase above the $3,000 level. That was a significant transition for us. Much of our energy went into making sure we got that right. One of the big concerns we had at the time, and when we testified at that hearing, the hearing before that, and then the subsequent hearing, my big concern, frankly, was the timeliness effect of that transition. We would be transitioning the purchasing of a prosthetic appliance with a vendor waiting on the other side of the transaction. So to complete that, most of our energy went into that. Now we're looking at the procurement compliance. Our audits are looking at the appropriate determination of the justification for other than full and open. If we're using 8123 incorrectly, our audits will pick that up now, and we'll make sure we're compliant, sir.
Ranking Member Kirkpatrick.
Reading here. I appreciate your efforts in crafting a national policy, but I just want to remind you that my district in Arizona is a huge rural district. It's bigger than the state of Pennsylvania, covers over half the state, and it's unique in that we do have a lot of rural veterans. We also have 25% of the population Native American, and you know, I'm always concerned about a one-size-fits-all excuse me, policy, and I'd just like to know how you're addressing the unique challenges and needs of rural veterans and our Native American veterans.
Let me take a first crack at that. We're a little bit off topic because I think once we move into rural areas, we're not talking about surgical procedures or probably even the involvement of vendors, but we are talking about providing services to veterans. And I think the VA has taken the lead in telehealth as a means for delivering care, what I would term to be point of residence, where the patient is. And I think we've made great strides in developing mechanisms by which we can treat and interact with patients remotely and provide rural veterans the same quality of service that veterans are getting in our larger facilities. It began in primary care. I think we're now able to deliver specialty care services. We have the ability to use stethoscopes and other remote monitoring equipment, so that I think we are being concerned about the rural veteran. I came from Omaha, Nebraska. Our area covered about 70 to 80,000 square miles of western Iowa and Nebraska. We faced some of the same challenges, and we found the use of telehealth very effective in delivering that care. VA is actually now looking at newer models which will deliver care directly into the patient's homes by connecting physician and patient across the internet so that they can interface directly in the home. So I think we are concerned about the rural veteran. We are concerned about the veteran that can't make our facilities, and I think we do have some tools to provide that care.
In my district. Well, one of my concerns is, though, communication between the VA hospitals and those rural veterans and Native American veterans, especially if you've got a device recall. So just hope that you'll keep that in the forefront of your minds as you go through the development of the policy. My other question is really, excuse me, process. The GAO report indicated that in 2011, the VHA established a program management office for prosthetics to identify additional surgical implants that could be made available excuse me, through national committed use contracts. However, an official told the GAO that the office was unable to focus on developing national committed use contracts because of staffing constraints. So would you explain to the committee how the office is supposed to function? Where in the organizational structure of VA is it located, VHA? Does it have the necessary staffing and financial resources to make a difference and improve the process? And do you believe this office is capable of performing the duties you have assigned to it?
That office is located in VHA's corporate office in what we call Patient Care Services. The National Program Director is on board. I think that program is running very well. There's a really strong collaboration between prosthetics now, logistics, and contracting. We attend concurrent meetings every Friday afternoon. We're reviewing the prosthetics order timeliness and accuracy. The committed use contracts, I gave a number very quickly. But at the below $3,000 threshold, these are the transactions that are micro purchases, typically done on a purchase card by prosthetic staff. 70% of those transactions are against contracts. In excess of 60% of the dollar value of those are against contracts. Those will increase. Mr. Chairman, in further response to your comment about the memo from 2012, we've seen an increase, although not where we would like it to be, in the use of waivers, and we have to do a better job communicating that requirement to the clinical community. Also, just to make sure people don't think of it as a punitive action, but as an informative action to let us know what else we need to get on contract. I think it's actually a really functioning partnership at this point, and the leadership team's doing a great job.
Thank you. Thank you very much. I yield back.
Thank you, Mr. Chairman. Dr. Lynch, I have a couple more questions about, I know you responded to Dr. Rowe's question about the tracking, and you said, and you know, we were informed about this VITAS system, Veterans Implant Tracking and Alert System, apparently which was in the process of development. I mean, can you elaborate on what that was, and what is the mechanism? Are we not using that, or what is the mechanism that you're using that you answered Dr. Rowe's question in the affirmative? How does that work?
First of all, VITAS was an attempt to integrate the systems we have that track implants. It was conceived and during initial implementation, evaluation was not found to be functioning properly. So at the moment, we have pulled that back. We're relying on the National Center for Patient Safety, who tracks recalls. We're relying on their interface with our networks and facilities. We have patient safety managers at each of our facilities who work with the National Center for Patient Safety to receive the recall, assure that any shelf product is immediately removed, and then work with the facility and its databases to identify any patients who may have had a particular implant placed so that we can inform the patient and the provider and be sure appropriate actions are being taken.
Has this actually occurred under your tenure there? Have you seen anything like that happen that you're aware of?
It has occurred seamlessly. There have been, I think, about 46 recalls over the past year that have been mediated by the National Center for Patient Safety. I can't itemize those for you. 13 of those involved biologics. They were all biologics that were placed in the OR, so we should have record of the implantation.
So then that information goes to each individual medical center, and then they, from their list of patients,
figure out if they've done any of those implants?
What they would do is go back and review the appropriate record to see if any of those are implanted in a patient, and then link that implant to a patient, yes.
So, you know how, does that take a long time then, or, I mean, is it done on computers? Is that?
The search is done by computers, yes.
All right.
And it's also tracked on a website. So, you know, an internal system, National Center for Patient Safety will issue an alert, goes to a patient safety officer at the VISN, who oversees the patient safety officer at the facility. And depending upon the criticality of the alert notice, there's a requirement to have 100% compliance by a given date. And that date is set by the criticality of the alert.
And there's a requirement that the medical center communicate with the National Center for Patient Safety to indicate that the appropriate action has been taken.
According to VA on that date, they don't track biologics.
Well, I don't know, I just got this answer here. In response to your answer, apparently there was a source from saying that the National Center for Patient Safety does not track biologics.
The National Center for Patient Safety does not specifically track the product. The facility does. The National Center for Patient Safety, however, does track the recall notices for biologics and does pass them through to the network and the facility when appropriate.
All right, well, I'm just...
In fact, there were 13 recalls within, I believe, the past year that did relate to biologics that were managed by the National Center for Patient Safety.
All right, well, that's contradictory to somebody else's answer at a previous date, apparently. So
I think the distinction is that at the National Center for Patient Safety, they're not keeping the list of the individual patient and the implant of that patient. That is not NCPS's charge. It's their charge to link to the FDA, find an incident report from a medical center, and then trigger the recall action and set the goal, measure compliance. The tracking is done both in CPRS and in the prosthetics GUI that will track that. So there are policies that require us to record the serial number and associate that with the individual patient.
Right, and I think, and just to interject for a second, what we've had is testimony and certainly evidence in the GAO analysis is that you are not effectively tracking this information, and that is a problem for patient safety. Dr. Benishek, please proceed.
Actually, I'm pretty much out of time here, so thank you.
Ms. Wolarski, Indiana.
Thank you, Mr. Chairman. Mr. Makovsky, I just wanted to ask a follow-up on the issue of the medical device tax. The reason I'm asking that question, the reason I'm concerned about it, and I've repeatedly asked the question of the VA, is because we've had complaints in my district, which is in northern Indiana, of long waits for medical devices, hips, knees, veterans even asking if they can, why the VA can't refer them to private hospitals, refer them to somebody else, get them the treatment because of enduring pain. And I posed the question to the VA way back in April of last year of saying, what is this impact going to be? Is there going to be an access issue? Which I've never received an answer on, but from what I'm hearing in my district there is potentially an access issue. And the other question I have was on this issue of funding. And I re-asked the question to the VA back in November on the committee, and somebody was here representing the VA, and they said they'd get back to us, and they never did. I've never had an answer in 60 days. And the reason I'm reposing the question is to you today, especially because you're here testifying on this specific issue that we're talking about. When can you give me, even if the VA's answer is that the dollar value is minimal, all I want is the dollar figure the VA assigns to the medical device impact. When can I get that dollar figure that you guys are assessing to the medical device impact? Can you tell? Because my fear is if I walk out of here today and I don't have some kind of an agreement with the VA today, I've waited 60 days, even put the request in writing, and we still don't have an answer. When can you provide me the answer?
I would say roughly within 30 days. We do a forecast out for the prosthetic spend that we perform, and we're getting better at forecasting that amount. It's going to be somewhat challenging. I mean, we'll have to look at how much the device tax costs and then do some extrapolation on that. But I would say give us 30 days.
So I guess my response to that is I've given the VA 60 days and no response, both verbally and in writing. Can you provide me with that information by the end of the week, by tomorrow, 5 o'clock?
I want to do a good job and make sure we get it done right.
But my concern is nobody's answered the question. We've done everything here, and the complaints that I am receiving from veterans who are waiting for these products has to lead me to believe if there is an access problem in my district, is there also a dollar value problem with funds available to the VA, and is there an economic impact? So my concern is because of the fact that veterans are complaining and the pain that they are in the meantime, and the issue of asking to even go to private hospitals, to go elsewhere, well, asking if the VA would reassign them.
I will personally commit to you that I will make sure we get this answer to you. I'm saying 30 days. We have some concurrence processes and other things that I need to go through, so I can't necessarily commit those timelines, but I will make sure we get it done.
Thank you. Thank you, Mr. Chairman.
Well, thanks to the panel, you are now excused. Today, we have had a chance to hear about many deficiencies present in VA's handling, tracking, and procurement of surgical implants. I'm not convinced that VA has taken the appropriate steps to correct these problems, especially considering how many of them were addressed in similar hearings this subcommittee held nearly 2 years ago. This lack of progress on the part of VA is unacceptable. As such, this hearing was necessary to accomplish a number of items. Number one, to discover the extent of VA inappropriately allowing vendors to participate in hands-on surgical procedures. Two, to address the absence of an operational tracking system that would allow VA to determine what implants were administered to veterans in case of an emergency. Three, to identify the reasoning and effects of VA's failure to procure biological implants on the federal supply schedule, as well as its rampant and incorrect use of waivers. 4, to require VA officials to explain their inadequate response to these serious problems and determine what steps, if any, are being taken to correct them. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material. Without objection, I would like to thank again all of our witnesses and audience members for joining in today's conversation. With that, this hearing is adjourned. Let's do it. Thanks. Good job.
Thank you for your insight into the